stay back slightly for anterior rotation. Don't get into turning the feet and all that business. But basically it's a toggle type setup. On his cards he would mark it RE, recoil setup. We didn't recoil, but it was that type of a setup. Thrusting with the triceps and holding momentarily. And on the high-low table, you'll have to adjust the headpiece to let the head lay fairly level in the neck rather than kinking it way up or letting it drop way down to where it locks. On those people that cannot rotate their head, they will have to lay on their side, on the back of the shoulder, and again adjust the headpiece so it's sitting like this rather than tilted way down or way up. Now he got away from a toggle type adjustment because he was getting patients that were being toggled for a long time but ended up having condyle subluxations. He didn't care for the recoil for that reason. And so he went just to a thrust sustained as opposed to using a drop piece or a recoil. That's kind of the history behind that type of a setup. They will work on the knee chest table also if you don't have the high-low table. So either table is going to work for that Atlas alternate. The torque is going to be according to the position of the anterior tubercle. Whether it's clockwise or counterclockwise, just depends what the anterior tubercle is doing. For the other cervicals now, 2 down through 7, as alternate moves, we will adjust those face down. When we set up on those, depending on the size of the vertebra, take your axis and 7th cervical, and many times the 6th cervical, if it's a large spinous, we'll use a padded pisiform contact of either the inferior or the superior hand. Superior being toward the head, inferior toward the feet. Face down, the headpiece is level or 1 notch up. We do that to help the bodies open in the anterior. The only exception to that generality is the arthritic case that's already bent in this position, and there's no way you can raise that headpiece up without causing too much pain. Or the case where they have a torticollis or the whiplash is so bad that they cannot extend their head at all, then the headpiece may be lowered slightly to conform to their spine. Other than that, we will adjust these with the headpiece level or 1 notch up, and we keep it that way for all of our prone adjustments. For the large spinous contacts, superior hand will use more toward the knife edge region. We'll stand on the side of spinous laterality. If I have a PR axis, I'll slide in from inferior to superior, slightly right to left with the knife edge, so my contact ends up looking like this. Now let my fingers contact the tissue rather than keeping it in air like this, because that slides you around too much. Let your hand just drape over the tissue. The secondary hand comes in, stabilize, and both hands can thrust on this setup. Feet away through the disc plane line, eye to west, and a slight right to left or left to right according to the rotation. 7th cervical, you can do the same thing, once in a while the 6th. You can use the inferior hand, this padded portion of the pisiform, do the same setup, cradling the occiput when we get around the axis, or cradling the neck when we're down around 7 or 6. Here, the secondary hand once again. You'll need to stabilize the patient's head either with your forearm here or with a strap. If you don't, with these prone cervical adjustments and the upper thoracic adjustments, you will find that the head is hyperextending, it's bouncing, you'll just have too much slack in there. It'll hurt the patient, the vertebra won't move, and it'll take too much thrust. So make sure you stabilize the patient's head, either holding your forearm pressure there or utilizing a strap on either the knee chest or the high-low table. Maintain stability. Those are for the large spinuses. If it's a small spinous, mid-cervical or 6th, we'll use one thumb over top of another, again standing on the side of spinous laterality, draping our fingers around the neck and shoulder region, thrusting feet away, eye to west, with a slight right to left or left to right if there's rotation in there. Now that may not be a very comfortable contact for you, or you may not have the strength to move some of those. You can alter that by putting the thumb on the spinous and pisiform over the thumb. Very nice setup. You've got the control and strength with the pisiform hand, the specific contact with the thumb. Or if you had to use your little finger in some cases, supported with that secondary hand pisiform over the primary fingertip contact. So that would look like this. For those of you in the back. Thumb, and then pisiform over top. There. If the spinuses would be too tender to contact on either of those particular setups, we go out onto the lamina process. That's a broader area, not quite as tender. The inflammation seems to revert back through the spinous process clinically. So if we go on to the laminas, it's not quite as sensitive. Some of those mid-cervicals are so close together, they're so short, that it's hard to get on one spinous process. So if you get on the lamina, it's a broader area you can get on one vertebra. Then we will stand on the posterior lamina side, and our thrust will come mainly through the posterior lamina. The other side will be stabilizing, and we're using a broad contact there, less sensitive than the spinous. If the vertebra is directly posterior and there's no rotation, and you use the double lamina contact, it doesn't matter what side you stand on, and you can thrust directly P to A, I to S through that disc plane line with both thumbs. So those are your different choices in the prone position. A big vertebra like the spinous is on axis or 7, sometimes 6, either knife edge, pisiform, or padded in here. The smaller ones, spinous, thumb over thumb, or pisiform over thumb. If that doesn't work, then thumb on each side on the lamina, dual lamina contact. Remember to stabilize the head so it doesn't hyperextend. That's just like having them sitting and you got the chin too high and you just push them out of the chair. It achieves nothing, so make sure they're stable in the prone position. Any questions about the cervical alternate set? Great. Would you prefer knee chest setups or pelvic table and pelvis? It's going to be a matter of demonstration. Pelvis. PI and AS, and IN and EX. PI listing is adjusted either with a push move, pisiform contact, or a pull type move, fingertip, pushing once again involving a kick. You have more leverage to push it with the pisiform contact. Our segmental contact point will be on the PSS, and the bigger the subscript of PI, the higher on the PSS. Because we're staying at the top of the sacroiliac joint, we have most leverage for P to A correction and making that innominate rotate from that posterior inferior misalignment back into position. When you think about adjusting a PI ilium, many people think they have to thrust with a lot of I to S in their line of drive. They end up sliding into the lumbars or wasting their thrust in an I to S dimension. If your forearm is positioned I to S, and think about thrusting P to A straight into the spine, you'll get those to move. We're going to position the patient just like we did this morning. We're going to shift that leg around like we did this morning, and you'll find there's a tension point and resistance and a slack point with the sacroiliac joint, the same as there is with a lumbar. Now with a PI, if you're thinking as you take that leg toward the patient's head, it would make it more PI, wouldn't it? But if you don't take that leg up and take this tissue slack out, you'll have too much lordosis in the lumbars, and trying to push that PI will be just like trying to push a fifth lumbar when you don't have the slack out. So we'll have to check that leg position. As we make contact and take that leg forward, and we feel that innominate come back to our hand, that's a little too far. It's already starting to go PI there. We back it down just a little bit. Slack is out, but we haven't started to shove it PI yet. Then we roll them over. Shoulders about straight up and down. Our line of drive is going to be P to A, I to S with the direction of our forearm, thrusting straight into the sacroiliac joint. Flat hand contact, padded pisiform. Fingers pointing down toward the table. That's your PI setup. If they're not going for you, it's most likely because you're coming with too much I to S toward the head, not enough straight into the spine to move the vertebra. If you try to pull one of these or use that setup, you have to stand your fingers directly on top of the PSS region, the upper border. Roll them over a little flatter here, so when you kick down, you also thrust down at the same time. Here in the kick, we are carrying that innominate with our thrust with the fingers. If we thrust up, like going down into the table, we bring that pelvis back, we're resisting our own thrust. So here it's a little bit different. We're going down into the table, but concentrating more down and flattening that pelvis. When we thrust, we kick down to carry it in the same direction. When we push, stabilization, before we tried to hold the pelvis still because we wanted that to be stabilized under the lumbar we're thrusting into. With an innominate adjustment, we are contacting the patient's thigh. Our pressure is a little bit lower, so when we do thrust, that pelvis is allowed to move somewhat. If we don't, once again, we're resisting our own thrust, just common sense. So that would be the two ways to adjust a PI ilium on the pelvic table. The AS ilium, pretty much the same thing, in that we're going to thrust P away to reduce it. AS has gone anterior superior, internal, and slightly more superior. Or excuse me, just AS is anterior and superior. We'll palpate the apex of the sacrum, go lateral about 1.5 to 2 inches, depending on the size of the spine. It's a pisiform contact. If your wrist extends enough, you can point the fingers down toward the table to get that P-away line of drive. If you're losing contact with that much P-away line of drive, getting the elbow into position, your pisiform is coming off, you'll have to turn your hand and point the fingers back to you to maintain contact to get the line of drive where I'm pointing my elbow back down the shaft of the femur. And on this one, again, roll them into position. As we thrust, we go P away. There's enough S to I there in the elbow position that reduces that AS listing. AS and PI go this way and this way on that sacroiliac joint. So being at the end of the sacroiliac joint, thrusting P away turns them in either direction, as opposed to trying to push down toward the feet or up toward the head. That's what makes an AS work. You can try fingertip contact here in a leg thrust. There's a lot of tissue to go through with the fingertip, and it may be a very sensitive area if the sciatic nerve is inflamed, so it's really not recommended. If you need a kick, you'd be better off to pisiform contact and then use your kick. Thrust it at the same time. Everybody clear on those two? AS and PI. With IN and EX, the IN ilium can be pushed or pulled. It's a pretty effective adjustment either way. In both cases, the involved ilium is up on the table. If we pull it, it's easy on the doctor. You don't have to be bending over too far or pushing with your arm. Got the leg kick with you to help open it up. The fingertips hooked inside makes it a pretty easy adjustment. So preferred wise, I'd say we try pulling it first, unless something contraindicated that, such as a big scoliosis, or perhaps some other factor in the acetabulum that we didn't want to kick, etc. Yeah.
I found that with, maybe I'm doing something wrong, but with patients that are very limber, that every time I try to pull the IN, sometimes we'll get a couple of them.
Right. There's another case where it would be better to try and push it there if that's happening. You have a little less control on the limber one on the pull than you do on the push. So I try pushing. When we're doing a pull, however, 1 or 2 fingers inside the PSS, determine where the fixation is. That rotational fixation can be high, mid, low, or half, or the whole thing. Get your finger inside where the fixation is. Hook that PSS region. We're going to thrust down into the table. As we do that, that helps open the innominate up. We're pulling it open at the same time, just like that. Very easy adjustment. If you push it, the involved ilium is up once again. Here, the pisiform is the contact. We have to hook inside that PSS, point the fingers of the doctor back toward his or her abdomen. Hooked inside there, we're going to thrust from medial to lateral, and we will also torque here with our hand because an IN goes internal and also a little superior. So as we thrust medial to lateral for IN and torque pisiform toward the patient's feet, it opens it up and turns it down a little bit. Now that's not a bad adjustment either. Patient's leg that is flexed runs between your legs. Roll them into position. You could put a little downward pressure on the lateral aspect of their thigh to lock it up a little bit more, take more slack out. And when you thrust, again, allow that pelvis to move a little bit so you don't resist your own thrust. Either of these is a pretty effective move. Saying that, in the sense that you can get a good adjustment doing either one. If you want to pull it or push it, there isn't really one that's better than the other than the fact that a pull is easier work for you, I think. Yes?
Are you doing a little rock before you do your adjustment?
On the pull move, I probably would, just to get a feel for the tension and slack in the leg kick region, the contact, and the shoulder. On the push, maybe stretch them out a little bit here, but not too much of the rocking down there. I don't think it's necessary. Anybody else about the IN? The other simple listing then is EX. EX will be adjusted most effectively with a pull move. With a push move, it can be done. The innominate is up. As a pisiform contact, will have to go on the lateral inferior border of the PSS. Lateral because of EX, inferior because if you don't stay down there, you'll slide right off of that PSS. The fingers will point toward the opposite crest or down toward the table. We cannot roll them over very far because that would open the EX up worse. Our thrust is going to be lateral to medial. Has to come some P to A as we thrust into the spine with as much torque as we can muster toward the patient's head. When we're pushing an EX, the torque in lateral to medial reduces the EX. The torque in the push reduces EX and lateral to medial. So you really have to turn that hand pisiform toward the patient's head. That may be difficult to get that reduced. With a pull move, however, having the ilium down, segmental contact point is that lateral inferior border of the PSS once again. Sliding underneath that hip, bringing our pisiform and that tissue slack out of there so the pisiform ends up on that lateral inferior border of the PSS. Your fingers will contact the tissue, the gluteal tissue. You won't be able to reach this crest here, and I wouldn't try to do that because that'll throw off your balance where your pisiform was contacting, even on a child. You want the pressure to come through the pisiform, but these fingers will remain in contact as opposed to being off in midair. The forearm is positioned straight across the pelvis, and you want to keep it in close, so simply turn your arm to expose the elbow fossa, keeping the arm flat rather than out here. If it's out here, you're going to do two things. You'll lift them off the table, which won't adjust it, or you'll slap your arm onto the pelvis, and that won't feel good. So keep the arm in close. You'll have to flex it at the elbow. On the CX pull, we will position the leg like the rest of the pulls, help it guide the pelvic movement. The actual thrust, however, is done by pulling with the arm only. And so that involves biceps and pecs. And we'll have to lean toward the patient's head slightly with our balance here, because as we pull it across, we can torque a little bit for the EX. The EX goes external and a little inferior. So if we come across with it to close it, we bring it up a little bit with some torque. So that would be the EX pull. Arm flat, straight across, a little torque, so it leans slightly to do that.
How do you keep the lower lumbar from rotating when you're doing that?
You gotta be real good at it. I really mean that. One of the reasons for not kicking is to try and avoid lumbar movement and that adjustment. When I set up on somebody, I think it might be a little more clear to you. You've got to really make sure you've got the slack out of there in the pelvis, you've got them stretched out the right amount up here, and as you do that motion, make sure that you are not binding those thoracics. You're coordinating the 3 points. So when you do thrust, it's coming right through here only. You're letting the shoulder come along. That's how you avoid it for the most part. Not kicking and letting that shoulder come along, keeping that same relationship among the 3 contact points, and you won't twist the lumbars.
You say not kicking, what do you do?
The leg is simply guiding some pelvic movement. Again, I think it will become more clear when I show it on somebody. On On the others, we're actually thrusting down in the table arm.
Yeah.
On this one, we're sticking the leg up there and guiding the movement, but the actual thrust is right there only with the arm. Somebody got an EX that moves real easy? Do you?
An AS, yeah, like a gun.
Well, how big is the AS?
Not much.
Okay, well, we'll try it. Maybe it'll make it a little bit more clear to you. Which side is it on?
But
Okay.
you can't use your left hand, can you?
Sure. Better
Almost
with
got
my
it.
better with my left hand, so put that in your pocket. Just for that sucker, you're gonna get it. All right. Now, I found the PSS. I've got to be on the lower inferior border of it. And that's going to be right there where that fingertip is. So that's where I want my pisiform to end up when I go through the setup. I usually just stick stabilization finger in there, have them lift the hip up for me. Hello. Get the tissue, pull it into position. No, I don't do it anymore. So I get that pisiform on the segmental contact point. Now, when you make your contact here, make sure you're on that lower inferior border. If not, if you're up too high, you'll slide right off, and you can feel it. Just lift the hip. Okay. There. There. Now, at this point, here's a good habit to get into. Take the hand on the stabilization side, lift their knee up and roll that hip right back into your hand, all right? It tucks your whole arm right around that pelvis, doesn't it? I gotta bring him a little closer, make sure I've got room for that leg as we bring him over. Okay. Make sure this moves easy, not embarrassing. Okay. The leg is the same thing. I'm gonna make sure I've got the slack out of the sacroiliac joint area. So I'm gonna bring it up a little bit, right there, takes the rest of it out in this dimension. I'm just resting the hand here. I'm going to put my leg in position, bring him past vertical to the table. Arm is flat across the pelvis. I've exposed this. I'm going to stretch him here, back, there he's tight. Now I'm going to get a feel for it, a little pressure with the kick here, and that I'm just testing the pelvis out. Lift your chin a little bit more. There we go, just like that. Now he'll tell you I didn't kick at all. All I did was just pull that straight across, and the only thing that moved was right down in here. Now, I did that kind of slow there, but his moved easy enough to where it didn't take much more speed. But coordinate the three parts together, the leg simply guides, and pull flat and straight across like that. Okay? That clear it up a little bit?
How much P to A?
Well, thank you.
You did a good job.
How much P to A do you think? I'd like to guess on that.
Feet away.
Yeah.
I'm not really concerned about feet away very much as I am just pulling this flat across. The unit is twisted this way. I just want to twist it back this way, that's all. I don't worry about going straight into it. See, it's opened up. I just want to close it across. Openings
About
like
the
this.
AS.
I didn't really concern myself with that because he said it wasn't much of a section.
If you do have a pretty large AS with PI, do you try to thrust into the joint then?
If the AS is more pronounced, I may just push the AS.
In other words, you're saying going P to A is not effective on this on full type of EX.
I don't think you need to get P away for an EX reduction. I think you get lateral
Yeah.
to medial,
No, I
and it's more
realize.
effective to get lateral to medial with the pull than a push.
But if you have AS, EX, when you do that, you're just getting EX, is that what you're saying?
If you have your contact down lower, like in an AS-CX setup, which we'll show a little while later, you are pulling down first and then across. So you are getting some of that AS out of there, but it's not as effective way to reduce AS as a push is, for sure. I think that's what you're getting at, aren't you? Yeah, I agree. Okay. Any questions about that EX pull? The leg just guided the movement there. There was no kick in that leg.
I heard of another way out of an push. What do you think about it? You know, rolling him over more and then setting up that beating.
I can't understand come straight on there, feet away.
With the torque in it, it's like a set in the tables, the way it's went.
Uh-huh.
And I tried it, and,
Work for you.
well, I have some problems with that EX pole on some people. And so I would be, it was more effective than so.
Well, what can I say? If it's being done and they're moving it, making the change in the film, I can't say it doesn't work. But I know in our mind, when we're doing it, our purpose is to pull it flat across the pelvis. And that can be achieved with the arm thrust and without the leg kick. Some torque is entered in there.
Okay.
I don't know what else to say to you.
Well, that's one of those. Thanks.
Anybody else about the EX or the IM maybe? If someone would come up here for a minute, I'll just demonstrate the setup of those other simple listings. Anybody? Anybody, want to donate their body to science?
Can I get a close estimate?
All rights reserved. Now, let's do a PI setup here. There's the PSS. It's about that distance between my fingers. You have more leverage being at the upper border of that for the PI. So that's where my pisiform contact will be placed. Flat hand, fingers down toward the table. Draw the knee up. There it starts to tip it back. I'll relax it slightly. I'll roll them straight over. There. Shoulders about straight up and down. Stretch them out here. Back if I have to. Boy, you have a loose joints. Now, when we go to thrust this, the important thing is not being down here, being up here. Too many people don't get that elbow up enough feet away. So when they thrust, it's all wasted this way rather than straight in that way. See the difference? You don't want to go this way. You want to go straight in that way, into the spine. That's the key. And as we do that, my pressure here is not as heavy as it was for a lumbar adjustment. When I set it, it's straight in like that. And I allow the pelvis to move when I make the adjustment.
It's a lot more of a body drop than this.
You can use body drop here. When you're using body drop, roll them over and you're coming more straight down with the whole thing rather than down into the
You
table.
have to roll over hard to get that line.
You really would without getting the resistance coming into here like you do for a lumbar.
Your stabilization leg back more towards issue?
Yes, as opposed to more on the lateral aspect, correct. I'm staying behind here a little bit more, so I let the pelvis move a little bit. The pressure that I have here is more on the lower portion of my thigh and his, rather than up on the buttocks area like it was for a lumbar.
More like towards that knee.
Right down in here, yeah. Now I'm contacting up here. As long as my pressure is low, it's not going to disturb what I'm trying to do right there. That'd be your PI. And AS, we find the apex, come lateral a couple inches. If your hand can stay flat with enough wrist extension to get that line of drive, which would be about there, you can put your fingers in the same direction as the PI. If it doesn't, if you try and bring your hand and you lose contact, you'll have to turn your hand around to face you. Get that elbow in enough position for S to I, and then feet away, right there. Straight down. And here, you can body drop once again a little bit more behind, down in the pelvis, this way. There it goes, just like that. You didn't hear that, but it clipped a little bit on us here. So we're coming down the shaft of the femur, feet away, flat hand contact like this or like that. Feet away is the key here. You get enough S to I, getting that elbow in the position. Rather than trying to push it down toward the feet, you'll slide away from the contact and thrust area. Then IN, pull, and valvuline is up. Right there's the PSS once again. I'm sticking my finger right inside there, 1 or 2 or whatever. Here, we will use some leg kick. Bring them past vertical to the table, Stretch him out. That's as far as he can go. Now when I thrust, I'm going to pull it open and kick at the same time, letting the shoulder come along. Kicking down into the table and thrusting, pulling it open like that. Iron pull. Iron push. Hook inside there with the pisiform. Roll him over quite a bit to me. Stretch him out here and thrust medial to lateral and torque toward the patient's feet, which is in that direction here with the pisiform. Just like that, right there. That's your iron push. Question?
How would you compensate on a real-risk patient?
Leave him a little bit more vertical as opposed to rolling him over as much. Leg comes up higher once again. Tilt the pelvis to get the slack out. Same things. I'd rather try pushing that than pulling it too, because it's harder to control than to pull. EX push, not really a desired move. It's a possibility. Lateral to medial with your tissue pull. Flat hand fingers down toward the table. Don't roll them over very far. When we thrust, it's lateral to medial and a lot of torque. Pisiform toward the patient's head. Yeah. Requires a lot of torque. That's an EX push. Okay. Those are your simple listings. By simple, I mean what a PI, EX, that type of thing. When we start getting into the combined ilium misalignments, the subscript factor is our deciding factor to tell us if we would try pushing or pulling in the beginning. So let's say the PI-EX combination. And the PI is the major subscript, PI-10-EX3. Or like the doctor we did, AS, whatever it is, 2, maybe an EX6 or 7. We use those subscripts to help decide if we're going to try pushing or pulling. If I have a PI-10 and an EX1 or 2, the PI is the overriding factor there. I will try a push move first. Because the push with the pisiform is more effective, more leverage to reduce PI. If it were a PI2 and EX10, the pull is more effective, has more leverage to reduce EX than the push does. So we would use those to decide where to start. It doesn't mean that you could not pull a PI10 EX2 or push a PI1 EX7, something like that. But those would be our secondary choices because of the leverage that's involved with each particular setup. Were the Blue Angels flying today or something? Yeah. Shoot, let's watch them. Can you see them?
Yeah.
Everybody down.
Oh, you just missed them. They're coming back?
About 6'5", walking around like he was really king tut. And the one guy said they really are when they can fly like that. Talk about precision. It's really something. Okay, back to school.
They even crash in formation.
Yeah, they even crash in formation. Boy, you really gotta trust your lead man, don't you? Let's take a PI-EX push now. PI is a major subscript. We're going to contact on the lateral aspect of the PSS first of all because of the EX factor. The more PI we have, the higher on that lateral aspect we'll ride. If we end up pushing one that's more EX, we'll stay in the lower lateral aspect of the PSS. So PI, we stay higher, EX, we stay lower in the push, but on the lateral aspect of the PSS. Fingers are going to point down toward the table. The thrust, forearm into position. We will be slightly lateral to medial for EX. We will be slightly eye to west with the elbow for PI. But when we thrust, we think about thrusting straight into the sacroiliac joint, P away. There's enough eye to west there already. And when we torque, because of the EX, we will torque the pisiform toward the patient's head. So thrust in and torque pisiform toward the patient's head. PI-EX push, just like that. The torque and thrust is simultaneous. We won't roll them over too far, not as far as a lumbar because of the EX involvement. When we thrust, we do allow the pelvis to move a little bit. We have to do that. The rest rest of the stretching business is all the same. The PIEX pull, the ilium is down the table, have to go on the lateral inferior border of the PSS, irregardless if it's more PI. Because if we don't, we'll slide off of the PSS. Lateral inferior border, pisiform, pull the tissue across the innominate, so we end up with the pisiform on the lateral inferior border of the PSS. We'll have to angle our arm and our body toward the patient's head here and make sure we balance our weight on our leg that's on the floor, of course, rather than on their shoulders, what I'm getting at. When we thrust here, we come across for the EX and torque toward the patient's head with the pisiform for some of the EX, but mostly for the PI. There's no way you're going to be able to thrust P away to get the PI out and pull. So it has to be by turning the innominate. Remember, they tilt back and down, we turn them up and in. So we do that with the torque. So it's an archetype setting with the arm and shoulder, like that. That's how we do a PIEX pull. It's the flat across and the torque that reduces EX, and the torque only that reduces PI, rather than a P-way thrust. So there again, it makes sense to pull a PIEX with an EX major. Harder to get the PI out through just torquing. Now to set up on either one of those, the PIEX push, once again, we don't roll them over too far, we stretch them out. P to A, I to S, lateral to medial, torque toward the patient's head. Thrust in and torque at the same time. Now we have to make sure the slack is out of there, stretching here, etc., before we thrust, otherwise we've wasted that slack. That's how it would look. For the PIEX pull, again we find the lateral inferior border of the PSS, have them lift their hip up for us, slide under there, bring that tissue across, so we hook that pisiform on that lateral inferior border, tilt that pelvis to get the slack out, roll the pelvis into your arm. Here, I'm going to lean toward the patient's head slightly, making sure I keep my body weight on, in this case, my right leg. And as I flatten my arm out, we're coming across for EX and torquing up toward their head for the PI. So it's an archetype setting with our forearm and wrist and hand, like that. That's the PIEX pull. That's how we do the PIEX on the pelvic table.
Push is preferred.
If the PI is the major. If the PI is the major, push is preferred. EX is the major, pull is preferred. Simply because leverage is obtained with either of those moves for that particular part of it. The other one that runs pretty much the same is an ASCX combination. Pretty much the same, the type of thrust, etc. ASCX push, AS is probably the major factor if we're trying that first. Contact-wise, is pisiform. Segmental contact is going to be the acetabular ridge area on the lateral aspect, but remember, deep to that, 2, 3, 4 inches depending on the size of the patient. So we'll palpate the apex of the sacrum and go usually about 2.5, 3 inches lateral. Or palpate the PSS, go about 1.5 inches lateral, about 3.5 down. Fingers point down toward the table, flat hand, just like the PIEX contact, except we're on a different segmental contact area. Here, the tissue torque helps reduce the misalignment, obviously because we're not right on the bone like we are with the PI. So when we put our hand in position, we will torque the tissue in the direction we want that EX torque to occur, so we take the slack out of there. So when we do thrust and torque, it isn't lost in the tissue slack. So what I'm saying is, on that ASCX, we'll have to torque our hand like this on that tissue. Flatten our hand out, don't roll them over too far because of the EX, get the arm in position for AS, stretch them out, we thrust straight in for the AS and torque for the EX. At the same time, thrusting and torquing. Same type of thrust and torque as a PIEX. Of course, taking out that technicality that with PI there is I to S, with AS there's S to I. But what I'm getting at is the speed away and the torque is the same, just a different part of the spine. If it were an EX pull with an AS involvement, hip is down, we have to get underneath it once again. Here, pull the tissue down and then across. Our forearm has to come underneath the gluteal tissue. If we have the forearm up on top, we will not get anything with the AS. We've got to stay underneath it. So when we make the adjustment, we get that arc type setting once again. And here, we'll have to lean toward the patient's head and over the patient, so when I come across, I come down this way, that with my hand, and across for the EX. So it's a C-type or arc-type setting, down and across. So I lean this way to do that. And just as the PIEX and the EX does not involve a kick, neither does this. The leg is positioned to help us determine if slack is out. We put a little pressure there and helps us coordinate the three parts, and then we set it with the arm only when we make the actual adjustment. So there's no kick with any type of EX pull. The leg is there to help guide the movement, that's all. That's AS, EX, push, pull. Pretty similar to PIEX, push and pull. Good? Stand up and stretch.
On your AS push, when you're on the posterior aspect of the patient's thigh, are you also with your thigh tracking down?
You can take it down, yes.
Your leg is the same in both. Just how much notice that you put on your AS.
Yeah, it's going down more than the AS to give you a little bit of PI pull. Now, the other two combined misalignments are the ASIN and the PIIN. The PIIN can be pushed or pulled. In either case, the involved alien is in the upward position. With the PIIN pull, we try to pull first if the IN were the major subscript. If the PI were the major subscript, we try to push first. Either one can be very effective, however. With a pull move, fingertip contact inside the PSS. The more PI, the higher on the medial aspect. The more IN, find where the fixation is, invariably that's going to be lower on the sacroiliac joint and PSS region. We do use a leg kick here. It's down into the table once again. We thrust straight in for the PI and pulling it out for the IN. If you can torque your fingers, wonderful. It'd be torquing toward the patient's feet because of that. But with the leg kick and pulling it open, you should have enough leverage to reduce that IN. The PI, we're thrusting straight in as much as we can with our fingertips to reduce the PI portion, in addition to being on the upper border of the PSS. With the PI-IN push, pisiform hooking inside the PSS, and we'll thrust medial to lateral for the IN, torque toward the feet for the IN, and it's a feet away for the PI. So at the same time, thrusting in and turning our hand. PI, IN, push. Pull. So it'll look will look like this. Bring them over. I can bring them fairly flat because it just helps open the IN, helps me stand up my fingers for the PI. Kick and thrust down for the PI. Concentrate on that if it's more PI and you have to pull it. We're pulling it open for the IN and torque our fingers this way because of the IN also. So all together like that. Right there. PI, IN, pull. push pisiform, hooking it inside there, roll them over again, we can bring them over quite a bit here because of the IN. I got you. When I thrust, I'm going feet away for the PI, medial to lateral for the IN, and torquing toward the patient's feet for the IN. Like that. Just like that. The IN push. The last combined one then is the ASIN. With that one, we push it valve side up. To pull it, it's not real effective with a fingertip contact. There they go. You can try it, but it'll be a little more effective to use the push contact with pisiform and the leg kick if you have to use some leg kick. For the regular push, finding that acetabulum, coming about 1.5 inches over, so we're staying on the medial aspect of the acetabular ridge. Of course, deep to that bone on the soft tissue. We're going to turn our hand with some tissue torque, so we're torquing toward the patient's feet. Roll the patient over quite a bit. We come in from behind a little bit here with our body. So as we stretch them out and we thrust and use body drop here, we turn the whole thing down and around. Gonstead said this one required the most torque turning of any of them because it tended to bind up very easy. So we really have to torque that one down and around. If it won't go with that particular setup, you can try it with your fingertips. It may be very irritating to the psychiatric nerve. And if this doesn't work for you, use your flat hand pisiform. You'll have to lean over them like this and kick and thrust. Boy, you got lots of leverage right there. Torquing the hand and thrusting as you kick. Kicking down into the table. That would be the alternate setup for the ASIN where you can't simply push it. It's about the size of it. As far as the combined daily misalignments on the pelvic table. Questions about contacts, lines of drive, anyone you want to see over here? Is everybody leaving for chores or something? Cows and milk? I don't know. The sacrum is the other segment involved in the sacroiliac joints. Now that one is misaligned either to the last lumbar or to the innominate on either side. If it's to the last lumbar, we call it in the adjustment a base posterior. And that'll cover 3 cases. Number 1, the disc that is wide in the back under the last lumbar as it is in the front and or wider. That's your classic base posterior. So the disc bulges to the posterior. On that one, we can push it or pull it. Push is probably a little more effective because you can use your whole hand to set it feet away. We can lay the patient down on the right or the left side. And you may use figures such as innominate rotation, scoliosis, good knees, bad knees, poor hip sockets, etc. to tell you to lay them down on the right or the left side. It's a pisiform contact, first tubercle, unless the 5th lumbar or last lumbar spinous interferes with that area, then we'll go down to the 2nd tubercle. So we stay as close to the disc space as possible. This is the widened disc in the back. Flat hand, fingers pointing down toward the table. Roll them over fairly flat, more than a lumbar here. We're taking the whole pelvis in effect underneath the last lumbar. So we do allow the pelvis to move. We're not trying to make the adjustment in the sacroiliac joints, we're trying to make it between the lumbosacral joints. As we set it, feet away and I to S. We are rolling our arm and shoulder in this manner, closing that disc space up. It's wider in the back than what it should be. Gives you the same symptoms as a 5th lumbar or last lumbar subluxation. So lateral film tells you if it's 5th or 4th or 6th versus the sacrum. Feet away, I to S. Push it either side down. If you pull it, fingertips staying right up on that first tubercle, roll them flat, kick them down into the table, and thrust straight down at the same time. the
whole-
sixth lumbar that
Yeah.
was really not quite lumbarized, but showing some spacing in there, but there may be articulation on the AP on either side. I treat the whole thing as a sacrum.
And okay, what if they have fixation at the sixth, or not, they have nerve pressure? Of course, there's something, it's not completely normal, or sacral.
Well, since you'd be contacting on that first tubercle will probably be that sixth lumbar, if it's getting close to being a sixth lumbar. And it's no different than adjusting that base in that first tubercle unless the first sacral nerve that's causing the pain. I still treat it the same way.
Is there anything you change on your phone, the setting?
You may change, well, it may be more effective to pull or push if you're not getting a stable setting on those. Push is more effective on a chronally set. Okay? And on sagittal, a pull would be a little bit more effective. So the push, you could get a little bit more of that lift that way. Whereas the rotation sagittal, you could get that a little bit more. It may want to alter your contact. It may be that it's rotated base posterior on the right or base posterior on the left, the combined problem on the lateral and the AP field because of that. So it may change your adjustment of contact point a little bit from the center of the sacrum to either side. Now, the other case with the base posterior is when you have a narrow disc in the back, but you visibly see the base posterior to the last lumbar. On that one, we can use pisiform or thenar, depending on what fits in there best to fit the angle of the baseline of the sacrum. We obviously can't come with an eye to west line of drive on that, we just jam that narrow space more and there. So we'll have to come straight in, feet away, through the baseline of the sacrum. And that may be in several different dimensions according to the lateral film. It could be straight in, could be a little eye to west, could be a little S to I, it could vary. Your x-ray and your lateral film determines that. That's a narrow disc in the back, but you have a visible posterior artery, but no spondylum yet. In the last case that we call a base posterior, because that's how we treat it with a base posterior adjustment, is the spondylolisthesis. And on that, we will go P to A and S to I. And we use a thenar contact. If the thenar doesn't feel comfortable, like this, you could turn your hand around, use a pisiform like this. To get that S to I line of drive. P to A and S to I. And again, we're letting the pelvis move as we thrust. For either of those last two.
What was this for?
Spondylolisthesis, we treat that condition with base posterior adjustment, only when symptomatic.
Is that, that's the particular choice for this thing?
Yeah. For the spondylo situation, the pelvic table is our table of choice, and the push move is our move of choice. The next move of choice would be the prone and the high-low. Crank it up a little bit, lock the abdominal piece just above the crest of the ilium to give some support in there, and then thrust the feet away and S to I. The next choice would be pull on this table. The last choice, last resort, would be knee chest. So they have been, spondylo has been treated on the knee chest. If it's someone who's so big that you can't control them on the pelvic table, and because of their size, their body is too resistant on the high-low table, they try it over there.
The patient's just got capital Gonstead, it's spondyl. And so I can't really push it unless I push it on the other side. And try that.
Sure.
Because it moves well
Oh.
on the sport too.
Oh, sure, sure, that's all healed up. It would be best having that hip down,
Right.
because he's sure he's not pounding it up here. If you're getting it on the high-low, super. Dr. Gonstead was emphasizing the high-low as table of choice in his last year of practice. And so a lot of people started broadcasting that, and really, to really learn what he did, he had to take care of his patients after he left.
Sure.
Yeah, and I know for a fact that his base posterior spondylo cases were push moves on the pelvic table. This is marked right on the card, push right side down or left side down. Some of them were done on the high-low, but there's another one of those instances where people were moving too much, and so he said, do them on the high low. And he was saying that because he felt that was the safest place to do the least amount of harm and the best chance of doing some good was the high low table. But routinely, push was the choice. That's how Alex and Doug watched him do it. I saw him do a lot like that, but it wasn't that last year that he really emphasized that high low table.
Well, it's hard for,
It was harder for him to work, but he did it more because of what he was seeing come back, where people were failing to control the spondylum by doing too much improper adjustment on it. So, just like the nose turning in, you can do it that way, but the thing is, it arises because of some problems in people's technique, and so he just made a total reversal and said we got to do it this way because he wanted to make sure that things were done safely, the most chance of doing good. But you can do the spondylo adjustment as a base posterior, push, high low, pull, knee chest. All of those have been used. Now the wide disc in the back, wider than it should be, either side down, flat hand pisiform, first tubercle. I'll roll the patient over fairly flat. When I thrust here, it's feet away and eye to west with a little roll with my shoulder like that, and letting the pelvis move a little bit. With a narrow disc in the back, but no spondylo. Could be thenar, could be pisiform according to the angle you have to get with your line of drive, which is the baseline of the sacrum. On that one, we would simply contact and set straight in, letting the pelvis move, rather than doing an eye to west line of drive like the one just before. With a spondylo situation, it's always S to I to the sacral baseline and P to A. So we'll use a thenar that keeps our hand off of the lumbars, S to I, stretch him and set it down like that, right there. If you don't have the power that way, turn your hand around to get that S to I and push it feet away, and S to I to the sacral baseline. Spondylolisthesis. Again, we only adjust that if it's symptomatic, regardless of the grade or how bad the pressure is, etc. It's not urgent, we choose to leave those alone. The sacrum, misalignment to the ilium on either side, is the rotated sacrum, P-R, P-L. And on those, we have three particular moves on the pelvic table. Our first choice for our easiness in doing it, simple for the doctor, a lot of leverage, is a pull move and valve side up. We will be adjusting that rotated sacrum, and is any question about whether to do the sacrum or the ilium, we use the general rule that if it's on the side of the ASIN or major subscript of either of those, we will adjust the sacrum to the ilium. If it's on the side of the PIEX or either major subscript, we'll adjust the ilium to the sacrum. That's a general rule, and that is when that's the sacroiliac joint to adjust. So it doesn't mean if you have an ASIN with a posterior rotated sacrum, that's a sacroiliac joint to adjust. If that's where the fixation is, and the neuritis, etc., then that's the joint you adjust, and then you decide whether it's sacrum or ilium. The rotated sacrum invariably rotates the lumbars all to one side, so that kind of gives things away. If it's on the ASIN or major subscript, or even if we don't have any innominate rotation, which is sacral rotation, the pull, move, and valve side up is very simple. Fingertips stand up inside the PSS on the lateral aspect of the sacral ala. One or two, maybe three if it's a large sacrum. Our thumb will stand up once again, making a little rat hole. We will kick down into the table. It opens the hip up. We thrust straight into it. So it's a real simple one. The other two choices would be push and valve side down and push and valve side up. With the push and valve side down, that will work fine if you have a small person, both in size and weight. The larger the person, the more the hip tends to bind up since it's already stabilized on the table. A smaller person, that table can help stabilize the hip enough for you. Without too much body weight, you won't get too much pressure into the joint to already bind it. So the valve side down, we will use a knife edge area of the pisiform, lateral aspect of the sacral ala, right inside the PSS. It will be a drive as far as head to toe is concerned, and slightly medial to lateral because of the angulation of the sacroiliac joints. They don't go straight feet away, they angle medial to lateral. When you roll the patient over to do that, you don't have to roll over very far because we already have the medial to lateral, the side is down. When you put a little pressure into the upper hip, that opens that innominate up because the table stabilizes it. There's going to be a point that's proper for setting in that if we leave it closed and don't put some pressure to open it, then it's bound. Put too much pressure in there, which is the danger if it's a heavy person, then the table and the hip are binding on the internal aspect. So the idea is we want to line that hip up so we can thrust straight into it. And you can feel that when you make your contact. As you bring that leg into position, make your contact and roll the patient over. As I put pressure here, I feel that hip open up right here. If I go deeper than that, it's open too far and bound in the front. And that's what happens on a heavy person. Now, you can take and put that pressure in there, let them relax and thrust, and make that adjustment, or you can leave the pressure off and body drop and thrust at the same time to make the adjustment. So it's a nice move there for the smaller person, because the weight doesn't bind them. With the involved side up, we'll use a thenar contact inside the VSS and the lateral aspect. On this one, we'll have to leave them farther back on the table. It works pretty good for the heavy weight. We'll roll them over quite a bit so the table helps support the patient. We'll get our pressure more on the lateral aspect of the thigh, so when we push it down with body drop, it opens the ilium up for us. And we have to get them over real flat because of the medial to lateral line of drive that we need in addition to the P to A. So thenar, roll them over, really flat. The pressure on the lateral aspect of the thigh. I can't get my wrist to bend enough to do this one, but the elbow would be down here and thrusting P to A and medial to lateral as we drop like that at the same time. So your weight and body drop here opens it up like it does in the kick. Medial to lateral, P to A. Thenar, so we keep most of our hand off of the innominate. That's the push and ball side up. So those are the three choices on the pelvic table. Rotated sacrum. Questions?
Preferred moves involved side down.
Our first move of choice would be pull and valve side up. We can do it fast. We can stay upright a little bit more. Do that pushing business. Kick and pull. It's very powerful. A lot of leverage. Yeah.
Okay, and the move is P to S or P to A?
P to A with respect to head to toe. We don't do I to S or S to I.
Okay, with the pull move.
Either one. Any of them.
P to A.
For the rotated sacrum. P to A and medial to lateral.
What was the move again to adjust the sacrum or ilium?
The general guideline is, which he found through clinical experience, and in the mechanics if you think about the problem, when you have the sacroiliac joint with the rotated sacrum, that joint is the problem for fixation, pain, etc. And that's on the side of an ASIN or a major subscript of either of those, AS10, EX1, that type of thing. We will adjust the sacrum to the ilium first, because in that particular combination, the sacrum is more posterior. In his work, we're always going for the posterior segment. So an ASIN, anterior superior, up and in even more, posterior sacrum is the most posterior. So we'll do the sacrum first. So we bring that in, they should come back and around. Now, it may not always. We may have to adjust that ilium eventually. That'll be our starting point in that combination, provided that's the sacroiliac joint, that's the problem. And you may have that and the PIX be the problem, just the PIX. If we have a PIEX and a rotated sacrum, the PIEX is more posterior than the rotated sacrum, and so we'll adjust the ilium to the sacrum there to start. And you may find in the case, you adjust that ilium, reduce it, that sacrum didn't come around, you have to come and set that in there too.
The chapters talk about inferiority of the sacrum. Do you deal with that in the adjustment?
Not too much anymore, no. Because of the distortions in the sacrum, anomaly is more the rule than anything else. And so we really don't stress that. They talked about torquing up on that lower side, et cetera. I think you'll find that if you compare your full spine projections to a sacral base projection, you'll find that the actual sacral base, and there's a plateau there, a very small amount, maybe lower on the opposite side of the sacral dip. So what you'd be doing in turning that lower side, let's say you've got a sacral dip indicating low on the right, and take a female, very common for them to have a plateau sacrum. That may be low on the left, creating a rotatory scoliosis to the left. You go adjusting that rotated sacrum to lift that right side up, you're lowering the sacral base plateau on the left worse, so you can increase the curvature. So, due to inaccuracy of that particular part of the analysis, we don't really concern ourselves with that. So much rotation being the major factor. Is there another question? What are you guys doing, watching the baseball game there?
I watched it last again.
Did they really? Oh, I'm going home. Did they really?
Girls last stand.
God, you gotta get yours, yeah. Yes.
If you have an increased lumbosacral hinge, with no posteriority of the base of the sacrum, and you don't have a nail problem, you can take that like a spondyl, take the sacrum, and obviously setting the fifth lumbar, you can't get enough leverage or enough set on that thing to get it over on the sacrum.
I think what you're saying is if the sacrum on the lateral is laying pretty horizontal, where the face of it, or the base is almost vertical, and you have a real sharp angulation to the fifth lumbar, there's no way you're gonna get that fifth lumbar onto that sacral base, that's true. And on your AP projection, you don't measurably have any particular nominal misalignment. To answer it the way he would answer it, he would say there's still one PI ilium in there someplace. Some distortion one to the other, and he would treat it that way. That's how Clarence would have answered.
You would have said that it was
He would not have set the apex of the sacrum. He would have still approached it from one ilium being PI to that sacrum, making that sacrum go flat.
If he had no PI on the X-ray, as far as motion palpation, what would he look for that PI?
He may look something up in the upper cervical region, like a condyle doing it, making it affect lordotic.
No, I mean, if he was gonna, without X-ray at all, if he was just looking for a PI, what would he, as far as the motion palpation?
For PI, it's pretty hard to determine that in motion palpation. You can determine rotation, fixation, visualization. PI, leg checks are what they try to determine with that, and they're not very accurate either. I would say he would never try to determine an ilium misalignment with visualization, other than in visualizing a patient laying prone, the gluteal tissue, whether it's flat or humped, indicating EX or IN. That's about it. He was very much against leg checks to determine PIs.
You just said you would check upper, the condyle, do you consider a rotation more so than say an SFPS or
The rotation of the condyle.
to create that hyperlordosis? Would you consider more of a rotation or the AS?
The yes or the PI.
Either of them could give that?
Possibility.
When you say that I'm talking about the direct leg check, okay? Did he, do you consider that accurate as to fixation at all?
You mean when they lay it face down and put pressure up here?
No.
And watch the foot flare?
No, when you're laying prone, both feet bring it up, and one comes up higher or lower.
I didn't know that indicated fixation. I thought that was supposed to determine PI.
Yeah, that's what I'm asking.
That doesn't mean fixation.
But I mean, did he consider that accurate as to a PI?
No,
Okay.
absolutely not, because you can get the same check occurring with an ASIN rotated sacrum, doing the same thing with the leg. You can do it with an atlas subluxation. You can put someone down, do a leg check, go out and put pressure on their atlas for a minute, do another leg check, it'll be different. The paravertebral muscular spasm. So what we're saying is we don't rely on leg check at all. Even to determine the nailing problem. fixation, we'll rely on palpation of the ilium in the sitting position invariably. Just sit up. And all we're doing, you've probably all seen this, is palpating the sacrum and the PSS with the fingertips. One on the PSS, one on the sacrum, and we'll rotate the patient's spine. We're feeling for the relaxation and the disappearance, in a sense, of the sacrum from the fingertip as we rotate. As I rotate his right shoulder back, the left sacrum side, or ala, should rotate forward or loosen up. So we palpate that from the top of the sacroiliac joint to the bottom, and then go and do the same thing on the opposite side, all the way up and down the joint, comparing one side to the other. It's always comparative value here, determining which of the two sacroiliac joints is a potential problem. Now, you might have both sides fixed, but one is fixed worse than the other. You might have it simply that one side's fixed, the other side is free, or you might have both sides moving, but one moves better than the other. Seriously, so it's a comparative value to determine which ilium to adjust. Now, in the chapters it says we list the ilium on the side of last lumbar body rotation. That's all that means, is we list it. That doesn't mean in this concept work that we adjust that one automatically. It may or may not be the one that we adjust. We list it because percentage-wise, that usually is the one that is involved, but not always. When we have that listing there, if we palpate and determine it's the sacroiliac joint on the other side, and on a card, let's say it says the left one's ASIN, but we determine by palpation, neuritis, etc., motion, and edema, that is the right sacroiliac joint to do, well, we automatically know it's a PIEX. We know what the subscripts are because we put down this is an AS5IN3. So we know this is a PI 5DX3 automatically.
I have a tall lanky patient. On AP, there were no subscripts in the pelvis. On a palpation, he had a definite IN fixation on the left with classic IN symptoms. Do you find that around?
Not really very often, no. But if you found it through palpation, it may be just enough rotation there, 2 or 3 millimeters that didn't show up on the film because of positioning. Go ahead and set that.
Kind of fairly common to find the SI joint pain or pain significantly from SI problems from the diaphragm.
It occurs, I couldn't give you percentages, I don't think it occurs real often, but the possibility is there since that nerve does go down through that region, and the inflammation from a lumbar disc, especially the last one, can also inflame the sacral nerves to cause referred pain to the SI joint. If the pain travels past the buttocks into the leg, then you're pretty well certain that it's going to be a lumbar problem. If it stays right in the SI joint and causes low back pain straight across the low back, it could be the lumbar or the ilium. If the pain is more dominant when they're sitting, you're safest to go with the lumbar first. If it's worse when walking, common sense tells you the SI joint's getting aggravated, so we'll go with the ilium first. Yes?
Your instrumentation, how much value do you put on the side of the brakes in the sacroiliac as far as the side of instrumentation?
Everybody hear that question? About the instrument? I would say if it's a slow heat break, Dave, I'd rely on that being the side. If it's a sharp break, that's usually the sacral nerve causing that, and that may or may not be on the same side. As far as the break is concerned down that region, usually you'll get a differential. That's going to be the wide sweep that stays hot the whole length and then swings back. And that should usually coincide with the aggravated side, because there we're dealing with capsulitis, palpable edema, tenderness, etc., restricted movement. That inflammation is there because of that, not necessarily because the nerve root is irritated. That may be chronic. You're picking up the normal temperature on the opposite side of the break. Anybody else? Well, anybody have some films they want to throw up here we can talk about, or Many people have a fear of being adjusted when they've been hurt, etc., and they shy away from the usage of this table, and I think it's the best table in the room. It makes a nice portable table, and you can adjust anything from the occiput down to a PI ilium if necessary. So we use it, probably not as much as we should either, but Gonstead used it for people who had difficulty holding their adjustments. You can get a nice deep set, a little deeper than the high-low because of the spine extension with the same amount or less thrust than you do on a high-low table. We use it for heavy people, we use it for the pregnant person, woman, I guess I'd have to say. We use it for someone maybe who has some sensitive rib heads or cracked rib, etc., that they can't take pressure laying on the high-low. Those are some of the cases where we go to the knee chest first. Sometimes we get a low back case that on the pelvic table we do not get the desired set and depth. And they put them here after we push or pull on the pelvic table. But you can use anything or do anything from the low back all the way to the neck on this one. As far as the setup of the table is concerned, we'll usually keep the support pieces in the first notch here and also back here, first or second notch. And that makes the headpiece a little lower here than it is here. And that will allow you to get that neck lordosis, open the thoracics a little bit. And usually it's most comfortable for the patient. If you have a taller patient, of course, you can raise this up a notch. Or maybe you'll have to raise up both the front and the back. Otherwise, that particular setup should get almost anybody. If you have a real short patient or a child, of course the table will drop a little bit lower by flexing that hinge. Routinely, we'll leave it right there. You can see it has a strap. As we mentioned yesterday, when we're adjusting these upper thoracics or cervicals, we want to support the head. And we can do that either with a strap or with our forearm supporting the head. As far as positioning is concerned on this table, I'm going to need someone right away. Now they can get down on the table just like he did, kneel first, and then reach for the headpiece with their hands. What we try to arrive at in the setup is having the shoulders and the buttocks about the same height. If they're about the same height, then we can adjust anything from the low back all the way up to the neck. The hands, as you can see, should be positioned on the little pads on the side. If they're dropped down to the floor, if the palms are up, that's fine. If the palms are down, they can push against the floor and resist you. The best position is right on the little panels or the pads. The knees should be back of 90 degrees a little bit. And what that will do is to allow the low back to drop down and relax. If the knees will be forward or flexed toward the abdomen, then they couldn't let their low back drop. If they're back too far, you find when you adjust the lower back that their knees slide back or maybe slide off the table. So make sure that you just have them back at 90 degrees. Now I'm going to make him move his left leg in a little closer because being right on the edge, again, if you were adjusting the lower back, that knee could slide off the edge of that foam. If you have about 4 inches, sometimes you can get about 6 inches between the knees. That gives them enough support for balance in this direction. On some people, because of the size of their legs or thighs, they cannot get that space without getting too close to the edge. So you'd be better to compromise a good 1.5 inches on each side and less between their legs, rather than trying to get that opening between their legs and having them too close to the edge of the table. So that's your positioning right there. We can adjust anything from here right down to here. In the Gonstead work, prone adjustments, we're doing what we call single hand contacts as opposed to the double transverse contacts saying diversified. If we're adjusting in the thoracic spine, in general we divide the spine into 2 sections, the upper and lower portion and then the midsection. We'll use our inferior hand as our primary contact hand for those upper 2 or 3 thoracics and for the lower 3. And for the remaining thoracics between those, we'll use the superior hand as our primary contact hand. That holds true whether you're on the high-low or the knee chest table. So the thoracic setups that we'll show in the next couple of minutes not only apply to this table but also the high-low. On the high-low table, the thoracic and abdominal piece is left unlocked, but we're adjusting the low thoracic up to about the fifth thoracic somewhere, fourth maybe on some patients. For the upper thoracics, 1 down through 4, 5, it's kind of a transition point, we will keep the thoracic and abdominal piece locked. You find it clinically will work better. The rib cage seems to bounce too much if we unlock that abdominal piece for those upper thoracics. So keep it locked for the upper section, lock down to the 4th or 5th thoracic, and unlock it for the remaining part of the thoracics on the high-low. If we have a spinous contact, you'll stand on the side of spinous laterality. If it's an inferior hand contact, we'll take that padded pisiform, slide that tissue from inferior to superior, a little bit of right to left or left to right, torque it slightly if we have a wedge, to take some of the slack out of that tissue and torque. Once we've made our contact, we'll keep our hand as flat as possible without involving more than one segment, rather than arching it. Arching your contact on the spinous can be very painful, so we try and keep it as flat and padded as possible. Then we'll come in with a secondary hand and stabilize either with our forearm on the patient's head or the straps. The line of drive for a thoracic adjustment, spinous contact, will be peed away through the disc plane line and a slight right to left or left to right. Torque if there's a wedge present. And we'll be standing on the side of the open wedge, so we will always torque to close the wedge. If it's an upper thoracic, it will look like this. Low thoracic, same thing. Inferior hand, primary contact hand. Now if it's a transverse contact, we'll stand on the side of the posterior transverse. You take your thumb or finger and pull that musculature away from the vertebra so you can slide your pisiform in on the transverse process. Then we will keep our fingers on the same side of the spine because of the rotatory scoliosis. Come in with the secondary hand, stabilize the head with the forearm or the strap, and once again, we're going to thrust feet away and through the disc plane line here. No left to right or right to left because it's a transverse contact. For those mid-thoracics, due to the imbrication, it's necessary to contact with the superior hand because in making a spinous contact on, say, a 6th thoracic, rather than contacting right on the spinous process, the tip of it, we have to go to the superior border of the spinous process, right underneath the tip of the thoracic that's just above it. So if we're contacting the 6th thoracic, we will slide up underneath the tip of the 5th thoracic spinous, slide in with our tissue, flatten our hand as much as possible, secondary hand, and the thrust is again feet away through the disc plane line with a slight right to left or left to right, and torque to close the wedge. So it'll be a set like that. If it's a transverse contact, standing on the side of the posterior transverse, once again pulling the muscle away, sliding in with the pisiform, flat hand, and the secondary hand, feet away and through the disc plane line. Those are the two single hand setups, spinous and transverse for the thoracic spine. Now, there are some additional ways to adjust these. A transverse adjustment can be done with the fingers crossing over the spine. You can change your thrust a little bit by extending your wrist when you thrust. And what that does is ensure that you make the thrust come down through the pisiform only, through the transverse, rather than the whole hand flat, pushing like you do with spinous or keeping the fingers on the same side. So if you let the fingers cross over with a transverse adjustment, which is permissible, make sure that you extend your wrist, snap it just a little bit. When you set it down, increase your speed a lot of times, and fit that right down in between the paravertebral muscle and the spinous. Makes a nice adjustment. Another alternate that will work pretty well in the low thoracic spine is the thumb contact. In the upper thoracics, because of the rib attachments in the sternum, the thumb contact is usually not very comfortable and doesn't work very well. Definitely not on a spinous. You might get away with it on a transverse. On a spinous, the thumb rolls around too much and it can be too painful. The thumb contact works nice on the transverse process of a low thoracic. It's a short transverse process. You have the ribs that are floating down here, so you don't have the resistance by the sternal attachment. And you can do it either on the hilo or the knee chest table. We stand on the side of the posterior transverse once again. Just place our thumb on the transverse process, right in close to the center of the body. Come in with a secondary hand, pisiform, supporting that, and thrust it, repeat away, with the disc plane line, and torque if necessary when there's a wedge. It's a very nice adjustment, real specific contact, feels very nice. You could do a spinous contact on those low thoracics because those do grow up pretty well straight. The imbricated ones, spinous contact is not going to work very well at all. But on the short ones, like 10, 11, 12, the thumb could slip in there. You know they get real close when you get the spine extended. So the thumb or even another finger could slip in there to make your contact, and then support it with the secondary hand. So of course we're thrusting here for the most part with the secondary hand, keeping the contact through the thumb. That's a nice adjustment, could be done on the knee chest or the hilo table. You may want to stand a little more directly behind the patient when you're using the knee chest to get that line of drive, which would be about in this plane at that disc level. It also will allow you to support the patient without pushing them away from that spinous contact. The very last resort in the thoracics that we will use is the double thenar. And that we will use if the spine is so stiffened up, locked up that we cannot move it single hand, or it's too painful to contact the spinous maybe, single hand. So we'll use a double thenar, standing on the side of the posterior transverse, taking the tissue pull inferior to superior, and then stabilizing on one side, thrusting through the posterior transverse side to make the setting, repeat away, torque according to the wedge. Is there a question? That's a very broad contact, of course, and chances are you will be moving a little bit more than the one vertebra, at least to start with. But it is an alternate that you can use to thaw some of those spines out that just can't tolerate any type of adjustment other than that. It gives a little bit more power with the arms, both in the same direction.
The notes say when using the chest to stand on the opposite side of contact and thrust into you.
That's for the lumbar spine.
Okay.
Low thoracic, depending on how much flexibility is there, you could also do it there. I don't think it's necessary up in here.
Okay.
It may have been said at one time and somebody wrote that down, but the thoracic spine with the rib cage is pretty stable. You're not going to be using that much right to left to push them away. When you do get down here, yeah, we will. Stand. And we'll cover that right now. Okay? Do we have questions all about the thoracics now? Pretty simple, I think. How you doing, Dave? You could get up if you want.
No, that's okay.
For the lumbars then, the prone adjustment, if we have the lumbar spine divided into two sections like the upper and lower part, we'll use our inferior hand for the low segments, 4, 5, 6. 3 is kind of transitional. It may fit better with the inferior hand on some patients or better with the superior hand on other patients. And then the upper 2 lumbars will use the superior hand as our primary contact hand. As this doctor was just mentioning, we will cross over, that is stand on the opposite side for either the spinous or the mammillary adjustment here. We do that because of the instability in the pelvis. If we were to stand on the right side to do a right spinous listing and have a little bit too much right to left, we could just push them away like that. Lose contact, lose the thrust, and of course maybe hurt the patient. So we will cross over. If we're doing a upper lumbar, like a first lumbar as a PL or PLS, I would stand on the right side on the knee chest table. Slide in and make my contact, flat hand, pisiform. I'll lean over the patient because I have to get left to right here. Come into the secondary hand. Stabilize the patient by placing my knee against the side of their thigh. So when I thrust, feet away, slightly left to right, and through the disc plane line, torque when there's a wedge, everything is stable rather than pushing them away. The same basis, if we have a mammillary contact on that upper lumbar spine, I would stand on the side of spinous rotation, contact the mammillary on the opposite side, therefore crossing over. That's what that means. I palpate that spinous, slide off the superior border with kind of a knife edge contact, following the angle of the ribs, keeping my palm off of the rest of the lumbar spine. Again, lean over. So when I thrust, it'll be peed away and through the disc plane line. That will be your mammillary adjustment in the lumbars, or the upper lumbar section. For the low lumbar section, inferior hand fits in there. Because of the pelvis, the superior hand will not work very well at all. So the inferior hand, if it's a spinous contact, PL, same thing, only inferior hand. Setting it back a little bit, left to right, feet away through the disc plane line. If it's a mammillary contact, crossing over, slide it along the crest of the ilium. Once again, leaning over, feet away through the disc plane line. On that last lumbar, 5th, 6th, 4th, whatever it is, we know the disc plane line is in an appearing S to I dimension. In order to get to that on many of the adjustments that we give, we will have to bring a little bit of lift into that vertebra, like we do a 6th cervical, to make it fit onto that disc. So if you're setting up on your low lumbar and just trying to push it in this direction through the disc plane line and it's not moving or moving very hard, it's because the facet is jamming too soon. You've got to lift that up and then onto the disc, and that requires a little bit of this type of action right there, and that'll make it fit very easy. So that may be one thing you'll have to do to change your low back adjustment like that. We can also use the thumb contacts in the lumbar spine. They work nice for the mammillary process because it's a small contact area. And on the knee chest table, we'll stand pretty well directly behind the patient. Place our thumb into position, and it wouldn't matter if you stood on either side. You could use the thumb over here in contact or on the same side in contact. I don't think that's critical since we're directly behind the patient. And then of course it's going to be the peed away and through the disc plane line, torque according to the wedge. Spinous process, it'll probably work all right for the small spinous like the last lumbar. That usually sits in there fairly deep. The thumb will fit in there as a good contact point on the segment, and then coming in with our secondary hand, this way or this hand. The big spinous process, probably not very comfortable. You slide around too much. The only time it'll work for you is if someone has a very hard or large paravertebral musculature with a little bit of a dip in there to where you really can't get your pisiform in position. You could stick your thumb down in there and then the pisiform on top of that, and it'll work all right. Otherwise, they slide around the spinous too much. Last resort, once again, would be our double thenar. Dr. Gonstead used that as the upper lumbar spine got very inferior. He would come in there with his double thenar and set it with a lot of lift, almost like a cervical once again, slide west, lifting it up onto the disc. And again, we'd stand pretty well directly behind the patient, thrusting through the posterior mammillary side, stabilization on the other side. That's one of the reasons this may work and allow you to set the vertebra as opposed to a single hand, is that you have a little more stabilization for the patient with the other hand, and thrust power with the thenar on the mammillary side. In the chapters, they show a double thenar on the last lumbar. You might get away with that, but it's a fairly broad contact used down there. I think it'd be really a last resort adjustment on that particular area. It's been done, so it was shown in there, but watching him do it, he used the double thenar for the upper lumbars. I mean, when he used the double thenar, that's where he usually used it, rather than the lower ones. Once in a while, the lower ones, but to give a little more strength to the setting with both hands, feet away. Otherwise, it was the upper section. On the high-low table, it's not necessary to cross over on your spinous contact, obviously because the pelvis is stabilized and it's going to be moving around. We will cross over with the mammillary contact just like we do on this table, however, because it's not very easy to fit your pisiform into that lordosis on the same side. Works better to cross over with the knife edge area on the upper lumbar, or like this in the lower lumbar, on both tables. In the lumbar spine on the high-low, we definitely leave the abdominal piece unlocked and leave about 6 inches or so between the bottom of the abdominal piece and the top of the pelvic piece. That will allow the lumbar spine to extend and relax. We leave those tables in maximum tension in the abdominal section and use our knee to push it down to get a feel for the give and flexibility in the spine. Then take our knee down as we adjust, if necessary. When you're making the prone adjustments, it's a good idea, whether you're in the thoracics or lumbars, to put your pressure in there, see how much give the spine has at that level. Right here, that's as far as that spine goes without starting to lock up. So I know if I just put my contact in there and don't exert any pressure, I can thrust from that point and not have too much slack to go through before my thrust actually moves the vertebrae. So we'll test that segment out, whether it's in the thoracics or in the lumbar spine. Test it out, let them get down. Now this one we can push down quite a bit. Right there's that tension, so I'm going to relax it from there a little bit. And then when I feel his muscles relax, from that point I'll make my set and hold it. That doesn't mean that we go down, come off, and go down again. What it means is we determine flexibility. Once we know where that is, we don't want to hold it at that locking point. It's just like any other adjustment. Find the tension point, back off with your pressure so there's a little relaxation in there. But don't back off of that and then go on. Hold it at that point and continue your setting with triceps extension here. How much adjustment, how much thrust, it varies with the individual. We would always start out with a light thrust like this and build it up with more if we need it to get the segment to go. Especially on this table, very light thrust so you don't hurt them, because they'll move easier here than on the high low. Just take a breather. And that pretty much covers the prone adjustment in the thoracics and lumbar spine for single hand contacts and the thumb alternates and the double thenar alternates. Any questions? Yes?
When you have, say, a patient that's extremely flexible and can really drop the abdomen, is it still a good tailor for the lunge, being with that flexible? For me, I don't know, it's just an experience, but it's hard to determine the tension point and when to begin to thrust.
The question is about a very flexible patient in this table. This table will work all right on the very low lumbars or the thoracics in the midsection or upper section. When you start getting into that lumbar lordosis, mid-lumbar, upper lumbar, low thoracic, on some folks it may work okay, on others, as soon as they drop that spine down and get the total slack out, they're already locked up in tension. And then they hurt, the facets are jammed so much that they can't tolerate any pressure. So I would say you'd be better off using the high-low for those people to where you can regulate the depth and they feel some support there. They'll let you have it a little bit easier. Or side posture on the pelvic table, maybe for a mid to upper lumbar on that one. The low lumbar, however, they can usually tolerate the adjustment there. That's lumbar spine sags down. You don't get as much pressure like you do in that midsection or the thoracics. Anybody else? Anybody want to set up on any of these? Is anybody here this morning?
We should go over the occiput on that.
Yeah. As far as what we can do here, it's pretty much just a PS or an RS or LS. Can't do an AS on this. And I can have it for a second again. It's pretty much a last resort adjustment for the occiput too. What we'll have to do is turn the patient's head to expose the right or left side. There. I'm going to put the arm up just like we did with the Atlas. And here we put a towel or something to support the neck. And you come in here with your pisiform on the occiput like the Atlas. And of course it'll be a sustained set just like that. It'll work. I remember one case that Dr. Gonstead had that he had to adjust it that way. He couldn't do it sitting. And it produced the result of what I it's the only time I recall seeing that done. But it can be done, and this table, I think, would work as well as the high-low table. So that'd be how we do it. If it was more PS, we'd come in a little bit more in this direction, more RS or LS, pretty much straight across.
Still want to try to get up in the groove.
Pretty much up in that groove area. Could get a little bit lower, but be careful not to get too low on the mastoid process. So I would say at least in the midpoint of the ear or up by the groove. And remember, that's a last resort type of adjustment.
If the lumbar spine were not flexible at all, in fact, difficult to even palpate between the various vertebrae, would you still use this, or would you do it on the pelvic?
If the patient's stomach cannot sink down and relax, we would never use this table on that patient for either thoracic or a lumbar. They have to allow that spine to relax. And if it's a ramrod type spine or someone that's bent over with an acute low back, we would first choose the pelvic table with a pull move on that. Anyone else? You have to relax on this table. There's no way around it. Some folks don't look like they're relaxed, and you can place your hand on there and kind of help them settle it down, and they can take the adjustment. It doesn't hurt over here when it's done properly. They can relax and you set it lightly. It won't hurt at all. It moves very easy. Yeah.
Did you say that the speed, in that adjustment is primary?
I don't think speed enters as much into the prone adjustment as it does, say, cervical or lumbar. Speed enters in insofar as knowing the exact moment that you can deliver your thrust. But you can see a thrust done on this table that appears about this speed, that's slow, but when it's delivered right at the correct moment when they're relaxed, you'll still move it, as opposed to a cervical or a push over there or pull that you have to have everything very fast. So knowing the moment's more important, I think, than the speed of it. The speed will come if your arms are relaxed and you extend your triceps. You can do it very fast. There are going to be cases where you have to do that. The right moment's going to require just the right speed too. But overall, many times watching him adjust, he'd have that contact on there and he'd just come up with his head and shoulders like that and slowly just clunk it in like that. Very easy. If the patient's confidence is there and they're relaxed, and you can detect that, then you can go a little bit slower and still get the segment to move.
Seems like the biggest mistake that I see made on that is bouncing off, not staying down.
Recall, yeah. That's a good point I didn't mention. Definitely hold your thrust, sustain. We do that on the high-low also, but on this table, much more important. Holding the thrust when we set it supports them. The adjustment will not hurt. What hurts is a missed adjustment or a recoil adjustment on this table. So when you set it and hold it, even if you have to use a fair amount of power in some cases, as long as you set it and hold it, it won't hurt them. Dr. Gonstead always felt some of the benefit using this table for a deeper set was the fact that you did get a slight recoil with the cushion. And if you held your setting, that would improve the depth of your setting. So definitely hold it in there. That doesn't mean for 15, 20 seconds. Just set it and hold it for a couple of seconds. You can feel their muscles relax. When you set it and you feel their muscles relax again, then you can take your hands off of there. And hopefully that's right away. If they don't go into the spasm, I can do it. Okay. Well, if we do some extremities, if there are no other questions about either this setups here or what we covered yesterday, anybody?
I'd like to, if you have time, to go in some geriatric case management.
What do you want to know?
Well, I had a guy who was 80 years old. He was in the bolster all his life, so he was in this position most of his lifetime. His spine was, like hyper type up. And he had a base posterior, but he could stand up, not for very long. And he wasn't really that symptomatic. The only time he was symptomatic is when he stood up and walked for a distance. And I tried setting his base posterior, and
of all, that type of situation is a relief case only that you have to offer. With that type of occupation all his life and degenerative changes, you are not going to make a lot of structural change, most likely. So, they have to be told when they come in, and you see that on the film or their condition that you can offer relief. And they probably need to see you once a month or every 2 weeks in order to maintain that relief, because you can only do so much with the material that you're working with.
Yeah. The thing was, he wasn't symptomatic, really.
Mhm.
You know, only when he walked would he get the pain.
Could you get any lumbar arch back in there?
He got a little bit more extension there, but he's, you know.
Maybe a little lumbar extension exercises against the wall, kind of pushing and extending the
Yeah.
abdomen, kind
Yeah,
of building
yeah,
that arch
sure.
back and limbering it up would help. Other than that, sitting or sleeping, making sure he's got good support there, sitting with a cushion back there to maintain that arch, sleeping with a mattress that's not so hard that flattens the spine or too soft that makes it bow like he is when he's working. That plus decent diet, those are all the things you can do to help relieve a case like that.
Yeah.
And then again, still getting back to the fact that at that age and that type of condition, it's like trying to do something with a 47 Chevrolet, you know, I mean, you can just do so much.
As far as the frequency of visit for an older patient, can you see, if they're in an acute case, can you see them every day?
Yeah, you can.
There's no problem with, any problem with the dynamic thrusting in the stable spine?
Well, the thrust is very minimal. Light thrust, just a light set. I wouldn't go in there to try and get a real hoop in soccer every time you'd set it. So, and I'd use the high-low table most likely, just to feed away thrust. Set it light, and they can tolerate that daily. You need to make little bitty progresses with those kind of spines rather than trying to give them real deep sets when you've got a good disc. They'll respond well, and then when they're relieved, I'd leave those alone and just kind of toy around with it and see how far they can go without needing a little help once again. You know, maybe you'll see them in a week, and if they did okay, then check them in a couple of weeks, etc. Get them out to the distance they can tolerate it with maintaining relief, provided you can't make any structural change. Of course, if we can, we'll try to do that. And the most change we're always concerned with is getting a lumbar and cervical arch in there. They don't have that. If you think you can get it, I'd work to do that like a regular patient. If not, then I would just get them out the distance they can go to where they're still relieved. And even on some of them, he would tell them, well, you go home now, and when it starts to bother you, then you come back. And that's, for some of them, they can go 3, 4, 6 months and feel pretty decent, and then start to get trouble. They're smart, they'll come back in and get it taken care of right away. Because, you know, you can offer 3 levels of care: relief, stabilization type of care, corrective, and maintenance type of care. And depending on the spine, the disc integrity, occupational things such as the workload, you may be able to go all the way to corrective care in a lot of patients, only to stabilization, maintenance on some others, and some just relief. And they have to be made to understand that from day one, and then reinforced. Because how many times have you told a patient, give them a beautiful half-hour report, 2 days later, how long am I going to have to come here, doc, you know, or when am I going to get better? And you pull your hair out and think, I just told you it's going to be 6 months, you know, something like that. So they have to be reinforced because they forget it. Okay.
A lot of the cervical with geriatrics.
If they can tolerate lifting the chin, lateral flexion, and et cetera, you can do them sitting. Again, the thrust may be just like that, very light, to get a little bit of a clunk in there, and that's all. And if they can't tolerate that chin elevation and some lateral flexion, or at least chin elevation, then I put them face down on the high automatically, thumb, et cetera, or knife edge, and set it feet away, very lightly. If it's restricted that much in movement, the spine is already self-limited, it's stabilized already, so you don't have to go through the lifting and the tipping and turning, etc. So all you need to do is go feet away with it, and it'll set fairly easy in the prone position. So you can treat those with degenerated discs. Just make sure your thrust is lighter. Anybody else?
Yeah, I heard conflicting stories at the rate reports or whatever, about in the initial examination, you should motion buffet or scope the patient.
Oh, I don't really think that matters what you do first. think that if someone's gonna rely strictly on the reading area for their concern, then it makes sense to or to scope them first and then motion the areas where you get the readings. However, the reading is not always gonna tell you where the problem is. In a lot of chronic cases, you may not get much of a reading at all, but you palpate and look in the film, well, there's definitely a problem right there, and you know that's where it is, but the reading isn't too bad. Well, there you rely more on the film and the motion than you do on the reading. And the more the acute the situation is, the more you can rely on the reading to be your starting point or hot spot, and when to back off with it, say in a low back case or whatever. So, I don't think it really matters. That kind of a deal is almost getting a little too nitpicky. I think you should scope them, motion them each visit, and compare that to the film. And then once you've zeroed in on your major, or 2 or 3, whatever it is, I'd motion them each time. And perhaps see a motion in other areas too that may look like there's restrictions, but it just isn't that critical what route you go as far as first or second. Where'd you hear that? Where'd you hear that? Remember? Dick? Martin? Alex?
The last summer, he said that you prefer that you scope the patient.
It's pretty much out of habit that when you walk in the room there at the clinic, the first thing you do is take your scope and run it down their back. And then they palpate, etc. So maybe he said it for that reason. I don't know. Or he may have said it, you know, there's a lot of people around now that will adjust just for fixation. I would say he probably said it for that reason more. Not to knock anybody's discipline, but just to adjust for fixations or reduce fixations is not, in our opinion, specific major subluxation type of analysis. So what I'm saying is, if you just motion all this fixation at the atlas, there's one at the 7th cervical, one at the 8th dorsal, and the 5th lumbar, and the right ilium, some disciplines will just crack the whole works, and the easy ones twice, you know? What he was trying to get across, well, you know,
Get every damn word.
yeah, he do, he foo, whatever type of language you like to use. But anyway, he will promote scoping first, I'm sure, because he wants you to zero in on the problem spots, not just to take fixation as the area to be adjusted. We are going to want to see, we like to see fixation, the reading, the x-ray, and the palpation, and the symptomatology all coincide and be present. Or they're rarely going to all be present like that. But the reading is a starting point for him, I guess. Well, for the clinic, because we always did scope them first.
What conditions are you real careful about in terms of not mixing epicervicals with rest of the spine or switching?
Any type of glandular situations, organ situations, allergy type situations. So you're talking about your blood pressure, ulcers, adrenal problems, thyroid problems, special sense problems, like eyes, ears, nose, throat, let's see, asthma, seizures, that type of
So
situation.
you would not do it in those cases, or you just?
I definitely would not mix. I definitely would not mix. I would clear out the area that I felt was the problem first, whether it's sympathetic or parasympathetic. And then if I still felt there was subluxation present in the opposite system, once I take care of the primary one, then I would feel safe to work in the other one. Okay? I think you're safe to work in both systems, perhaps on the same visit, if you have strictly a musculoskeletal problem. Meaning you got a low back ache and a upper neck ache, and you decided it's a 4th lumbar in the atlas. Provided there are none of those things I talked about, is strictly a fixation, muscular problem, tension type of thing. Dr. Gonstead adjusted the 2 areas together at different times, and we do. Not that we're trying to promote that you just adjust everything all over once again, but that's the type of situation where we would feel it would be all right to combine the two areas. We like to limit the adjustment to a couple of segments per visit, and hopefully can stay in the same system. The more you do per visit, the more you divide up the response in the body, the less effect you'll get. And on the first visit, we always do just one segment, usually. Otherwise, if you do 4 or 5, how do you know which one started getting better, you know?
When you have a patient that's really acute and you're first starting to see the patient, do you have the patient come back, say, more than once in a day? Maybe in the morning and in the evening?
Mhm.
Do you very often adjust the same segment in the evening again?
Absolutely. Sure. We may take like an acute low back case, you know, third, fourth, fifth lumbar, whatever it might be. We may set that twice a day for 5, 6 days in a row. Same segment.
Okay, now, I thought, the reason why I asked that is I thought, I was under the impression that when you guys at the clinic had a patient come back in the evening, it was because you didn't want to mix the nervous systems up and you didn't adjust the same segment again. But,
Well, there may be that case to where we do divide the day up for that reason, and have them come back later. But it could go either way. We've adjusted the same segment on the same day twice, or 2 different segments for that system reason on the same day, leaving a good 6, hopefully 8 hours between the segments.
What is the, I've never been able to understand in the case management notes, they talk about the sympathetic nervous system is providing the state put value. It seems, is there any?
I have never heard that myself. The stay put value has always been referred to the pelvis. I mean, as far as setting the foundation, making everything else above that stay put, if you will.
Heard that Gonstead used to say, listen to the person walk.
Listen to the person walk. I don't know anything about that. Any of you other older guys? You older guys, well.
I never heard him say that. What was the question?
Listen to the person walk.
Listen to the person walk.
Well, meaning the gait, observing the gait.
Oh, yeah.
Yeah.
Well, then he's just using the word listen figuratively. Oh, sure. Absolutely.
He watched everything, what are you talking about?
Yeah.
Can you go into some of the specifics of gait?
Oh, he'd be looking for,
positions?
yeah, he'd be looking for antalgic position, shoulder height, pelvic movements, limb maybe, foot flare, how the head is carried, that type of thing.
Need more specific. I know that, I've heard that with the thoracic, with the thoracic problem, that the patient will usually carry themselves forward, and with the lumbar, they tend to carry themselves more in an upright position, protecting areas.
Well, I think it could go either way, because I've seen patients with low back problems come in like this, and thoracic problems come in like this. I don't think you can use things like that, to decide what it might be. He would use visualization and gait to determine maybe that he can observe maybe some fixation or restricted movement, say in a pelvic area, as far as the length of the step maybe, or the way the foot is flaring, or the limb, or the gluteal tissue activity. Of course, visualization for wedging, if someone's walking and they're bent this way, well, a good chance the wedge is on this side, that type of thing. Or having the head pulled down, the wedge being here, that type of thing. Other than that, I personally don't know what else he would have done in watching the gait.
Could you go over the cervical pull move?
The cervical pull move was referred, or it specifically means the alternate adjustment for the INF adjustment. So if you've got the bifurcated spinous, and on the INF, if you have a PL INF, instead of kind of in here, it would be on the inside here, catching both of them and lifting it up. The pull meant you went on the other side and hooked that bifurcated identification with your finger and brought it up repeatedly. And I think a lot of people use it to mean you just go to the other side on the lamina and do a rotary. It's not that at all. So to say pull, that's what it originated as. Now, we will adjust people's necks. Let's say it's listed as a PL, and you just can't get it to move on the left side. Instead of beating the guy's neck to death in 6 or 8 thrusts, we will go to the opposite side and just go as feet away as much as possible on the spinous process, or if there's a terrific amount of rotation on the lamina, and go feet away to reduce some of the posterior inferior misalignment. Some people are calling that a pull. But the origination was hooking up microfusion. Anybody else? No. We can talk about some extremities here then. I'll need someone right away too to sit on the chair. Thought you're gonna get back at me for that comment.
Be careful when you get his knee.
Does he got a problem there?
He'll kick you. Fix his head. Fix his shoulder.
Now, we will do a couple of things for the sinus area. That's why you're up here, isn't it?
No, dying, that's all right.
You're dying?
Yeah.
What kind of flowers you like? For the sinuses, we'll concuss the frontal and the maxillary sinuses and massage the nerve endings around that area to help loosen up the material. It can give the patients a lot of relief. And on the frontal area, we'll take our thenar, place one hand behind the head and on the frontal sinus, thrust into it and torque out to loosen the material up. It can relieve those areas sometimes. We're not really looking for an audible or trying to move something here. But it's straight in and torquing out like that. We can do the same thing down in the maxillary area with the thenar, stabilizing the head and setting it down and out like that. Or the other side, we can come directly behind the patient with our fingertips, traction the tissue down and out like this. Massage with your fingertips in a circular motion. Help stimulate nerves around those sinus cavities. And concentrating with your index fingertips right next to the end of the nasal bone, where the cartilage begins, and where it fits the maxillary. Is that pretty tender?
Oh, no.
It's kind of curling your feet up. You can
I
feel
just-
this one's all
It's
puffed up.
really getting
Yeah.
me at a bad time.
Don't what?
Kill me off in the process.
I wouldn't do that.
Oh, okay.
So we just massage in this type of motion, set it down and to the side like that, to milk the area, stimulate some nerve activity. And many times they'll start to open up in clariform, either in the room or when they get outside. It helps them an awful lot. It's something they can do themselves to help relieve the area. So those are the two things we would do to the sinuses directly. Other than that, we don't do stuff inside the nose, etc. The jaw, next thing up in this region. It's something that can cause all types of symptoms, from facial pains, tic douloureux, Bell's palsy, cluster headaches, pain in the mouth and teeth, numbness in those areas, blockage in Stenson's duct, etc. could cause pain around the side of the face. It can be affected from the jaw. It can also have plain old headaches, ear problems, ringing in the ears, ear infections that keep repeating themselves, or the plain old clicking and pain in the jaw joints. And it can result from either chewing on one side of the mouth all the time, or biting on something hard, or being in the dentist chair for 2 hours and tractioning the jaw open, etc. On these, we can offer relief and pretty good stability if it's a real acute situation, short-term situation. If it's long-term, chronic, and they jump and move around a lot, we can't change them too much. So what we'll do is stand behind the patient, palpating the TMJ with our fingertips for symmetry or lack of it. Palpate it for symmetry in the distance between the front of the mastoid and the back of the jaw. For swelling and protrusion of the condyle of the mandible in the TMJ, and then we'll watch the tracking of the jaw as they open their mouth. When they open, we'll feel for symmetry and the protrusion of the condyles. We'll also follow the tracking as they close the mouth. What we like to see is the jaw come up straight. When we run into troubles, we'll feel clicking, we'll feel protrusions on one side or the other and palpation, and the jaw can go down and drag to one side or the other side. When it returns, it comes up to one side first and then the other side last. The side that it returns to last is our problem side, because the jaw routinely will get strained or misaligned, dropping inferior, then sliding forward. And so if it's down and forward on the side that's involved, you'll see the jaw swing away from that side when it's opened and return to that side last because it has a farther distance to travel to return to its position. When we determine what the problem side is, then we'll help our contact with our hand on that side first, and then come in with our other hand on the opposite side. We're making contact with our fingertips underneath the chin, with our hand along the body of the jaw. Our padded pisiform area is underneath the angle, and our thenar is against the ramus on the side. Because we may need to push in with the thenar, pull back, lift up, etc., a combination of those things to get this to return to its position. When they have it opened, and we go to make the adjustment, the first portion of the adjustment is to pull the jaw straight back. Now we're instructing the patient to close their mouth as slow as they can, and we'll pull the jaw straight back. What you'll feel is a little give or relaxation on each side, individually or simultaneously. The whole thing will slip a little bit or relax. When you felt that, then you can start lifting it up, but not before. The idea is it's down and this way, we've got to bring it back and then up. So the first portion of the adjustment, he would say usually the first third, approximately. We're simply pulling the jaw back as they close it, pulling it back, and then putting pressure underneath the body and the angle with our palm and our pisiform, lifting it up. If necessary, holding pressure into the thenar, if the side is also protruding out. And we'll either feel it slide up in as we do that, or click in there, or it may be that we have to close the mouth entirely and then give a little set underneath the angle of the jaw on the involved side to set it into position. And it may take you several trackings to get that to fit. By that I mean 3, 4, 5, or 6 sometimes to get it to fit. If you cannot move it, it's too painful, or it just locks up too much, the next best thing you can do is traction that joint to take some of the strain off of the soft tissue. To do that, again, we'll be directly behind the patient. We'll have them keep their mouth closed, supporting underneath the body and angle of the jaw with both hands. You've got to be careful not to get your hand in their throat or Adam's apple area. And what we'll do is instruct the patient to try and open their mouth. And as they do that, we will hold pressure on their jaw so they can't open their mouth. What that does, is traction these ligaments in here. And sometimes as they stretch and traction, and then they return to their normal tonus, they will help draw that jaw in position, or at least relieve some of the pressure, so maybe later in that visit or the next day you can set that jaw. This will give them relief. And we do that 3 or 4 times, holding pressure for about 5 seconds and then letting them relax. They try and open, you hold resistance about 5 seconds and then let them relax. Repeat that about 3 times, and then wait till the next visit. Or we'll make a round and come back and see if it'll set after that. It's kind of like doing that stretching business with the torticollis we talked about yesterday. You can just give enough stretch to it to momentarily take some of the spasm out of the area, and that may be all that it takes to get it to move into position. Any questions about the jaw?
When you're setting it into the fossa, are you trying to get a snap out of it, or some kind of jump to have it, or do you want it to, you want the fluid to just flow over the mandible so it just...
We'd like it, the fluid to just flow so it just kind of slides.
Milk
into
it
place.
right in.
Yeah.
Okay.
Some of them you'll find when you do close it, there'll be a point where they have to jump a little bit. And until it does that, it's gonna be fairly painful on the patient. So watch your pressure. Lay back on the pressure a little bit. If you can see when they open it, it's got kind of a double click, and it juts and jumps in there. When you come back with it and start to lift up, lighten your pressure in the beginning, and when it jumps, then you can hold your pressure, slide it up in there. Next area would be the clavicle. And on that one, of course, we can have a problem either at the sternum or the acromion process. With the acromion area, invariably it will be strained straight up. In the film, you'll see a separation in the space. Of course, in palpation and visualization, it'll be elevated. The easiest way to work with this is a traction type move. Simply take your finger, index finger, roll it right over top of the acromion process, or excuse me, the clavicle. Then take their shoulder. I'm holding pressure straight down on the clavicle first, and then simply raise the shoulder up slowly. Work the shoulder a little bit like this, if necessary, and that'll plunk right back down in position. In the acute case, of course, when it's swollen, ice would be indicated, and you may have to repeat the setting a few times to get it to stabilize down there. That's much better than coming like this and trying to shove it down on the scapula. Distraction move, holding pressure first. You must hold pressure here, and then simply raise the arm up. Some of them you'll have to move the shoulder around like that in order for it to slip into position. That's the nicest way to do that one.
Is that usually on?
Not usually audible, no, you feel it usually. He has a little activity right there. When I did that, he didn't hear anything, but you can palpate that. With the clavicle, the most common problem there when it runs into the sternum is getting shoved toward the sternum, and then it subluxates or strains anterior. And so a traction move for that would be standing behind the patient, raising their arm, taking the fingertips of the arm that's underneath the problem side, hooking the front of that clavicle with your fingertips, coming around with your other hand, and using a contact on the fingertips. You simply raise the arm up and bring it back, stretch it slowly, again a traction move, and clunk, it should slide back into position. If it's acutely swollen, you may just be able to traction it, take some of the stress off of it, ice it, and then come back and try it again. If you can't get the arm up high enough, or you're not getting it to move, that means the arm isn't up high enough and back. You may have to lay them down on the high-low on their back side, and then flex the arm once again like this. With one hand on padded pisiform, just put pressure in that direction. With the other arm, you're raising their arm up and back, and you can really take it as far as you need to go when they're laying on their back.
How stable are those after you adjust them?
They're not real stable. It would depend on how bad the tear was, but they'll usually heal up with some calcific residuals, and they will be cosmetically protruding there usually to some extent. You can relieve it. That's about it.
Would you want to take that or anything to try to put down?
I suppose you could. I don't know how much that's going to help it. It's like a broken clavicle. They don't really do anything for it except let it sit there and heal. I don't know how you can make it too stable. Other than inactivity, slinging, maybe not using the arm on that side.
That's what
Okay. Now, shoulder. That's a biggie in the practice, usually. The common problem there would be the shoulder that's dropped down and forward, AI shoulder. We can have several ways to do that depending on how much range of motion they have when they come into the office. If you can take their arm and do this, take a good circumduction range of motion, and you can do the adjustment in the sitting position, standing from behind, and lifting it into position with both hands. And by that I mean checking the motion here. As we come up and around, we'll start to turn the arm. As we do that, I'm holding pressure under the elbow so I don't lose things. Tuck it back into their side, turn their palm toward you, come from behind, stabilize the scapula. With both hands, we're setting it straight up, inferior to superior. If it's not setting, you may have to turn the elbow into the body slightly and come a little medial to lateral and torque slightly to suck that back into position. Torquing it just a little bit to make it set. That should be able to get it for you if they can do this. If they can't do that, let's say their range is restricted to frozen shoulder, or it's too painful to do that type of lifting type set, the next best thing you can do is traction the shoulder. And you can do that either with your forearm or a towel or something underneath their shoulder. Come under here, grip the wrist, with the forearm in the axilla, gripping the wrist. You'll put pressure straight into the side of the rib cage, and be very careful on elderly folks because of the poor mineral densities in their bones. Their ribs may be pretty sensitive, or you can bruise them if you put too much pressure in there. So what we'll do is simply stretch that shoulder out. I'm tractioning. I'm doing that because my arm is in the fossa, or the axilla. I'm putting pressure straight in to the elbow here. As I do that, that stretches the shoulder ligaments out, and that will give them relief. And we can also lift a little bit, and sometimes they'll set like this. They can't tolerate that circular motion, but you can push it straight in and lift a little bit, and then allow it to set into position. Audibles are heard in many of these cases. In many cases also, it's just a feel. You feel it move, slide, etc. The patient does also. If you get a frozen shoulder and you're stretching it like that, and that's all they can tolerate for a few visits, don't try and set them. Just let it stretch out, and they can do the exercise at home for you. Stuff a towel in there, turn their hand toward them, and pull their elbow in, stretch that shoulder. About 5 repetitions, 3 or 4 times a day to start to limber that up, and then you can come in and make your adjustment. Another way you can set these is to traction the arm straight down, takes pressure off the joint. Keep a traction on the arm, turn the palm up, get your forearm underneath the arm, and lift right here. Clunk. This is one that usually works if you cannot get the range of motion setting like that. Then you can stretch them down, pull it out, turn the palm up, holding pressure or tractioning all the time, and then just lift it up and into position like that. Work it a little bit and set it straight up into position. That'll be another way to do that shoulder that's dropped down. The dislocated shoulder would be done that way. If you happen to get a case like that, that it's dislocated completely and sitting under the pectoralis or something, then we're going to need another person to help you stabilize their shoulder. But what we'll do is grip the elbow and the forearm and traction down as far as possible, and keep a strong traction the whole time as you bring the arm out, holding that palm up and going through the same thing. Their tendency will be to raise the shoulder up all the time, so you need someone holding there. And then at this point, many times it's already sucking back into position. But if you traction it, that helps take a lot of the pressure off. And then that tractioning, once you get that shoulder somewhere close to home, those ligaments will suck it right back into place. It's a terrible sound, but it'll go right back in like that.
You definitely buy the dislocation.
Excuse me?
You buy the dislocation.
Absolutely, sure. The taping business strands this way, so we hold it up, and across this way, and of course the slump. Absolutely. You probably won't get too many of those unless you're with a football team or something. The other way the shoulder can get into trouble is having someone fall or brace themselves and shove it back and up, that posterior superior shoulder. On that one, the pain is usually localized in the back part of the joint. And on that one, traction move again is about the best thing to do. And you can grip the head of that humerus, holding pressure down, bring the arm up and back, and just pump it back into position very slowly, doing that circular motion like that. That's the easiest way to do that, the less strain on the joint as possible. Some folks like to take the arm and straighten it out, turn the palm down, and do that same circular motion, bring it up to the top. As you start going down, slowly pump that and roll it into position like that. That's another way to do it. Be careful not to put too much pressure or really try and shove that down, because you can hurt them very easy. So traction, holding pressure down as you raise the arm up, that should get it for you. If not, as you do that circular motion, just pump it as you go on the downswing, not when you come back up.
Not want to work on that. Putting the forearm or a towel under there and traction the humeral head out. Do the same.
You wouldn't have to do it for that one unless it's a frozen shoulder and that's what's happening. Then you'd put the towel in or your forearm and traction it out to loosen it first. Otherwise, you can go right to that if they can do this. Put pressure down, raise the arm up, pump it a little bit, and then go to circular motion. Pump it as you're on the down swing of the circular motion.
Is there any symptomatology that would differentiate between the anterior and the posterior?
Symptomatically, the pain on the anterior ones is invariably in the front here, and the posterior ones is back here.
What about reaching back this way, sir?
Either one of them could prevent them from doing that. More commonly, the anterior one prevents them from getting their arm up to do their hair or whatever. Posterior one from getting around here, because as you try and bring your arm around, it's gotta go in this direction. It's fixed back in that direction, you can't rotate it, so you get it back and around. But both of them could give him trouble going this way. This one, usually the anterior one.
Another question on the shoulder. You got a lot of athletes, baseball players that get diagnosed as having the torn rotator cuff. Do you find there's a subluxation of the shoulder joint involved with that, or? in place of an
Usually
actual-
there is, or maybe in place of that, because they're constantly throwing that shoulder, expanding that joint. In the old days, I don't know if they still call it, you threw your arm out, you know, and that's what they meant. Once a person did that, they did a damage to the soft tissue, the shoulder was loose, and unless they were very, very careful about warming up again, from that time on, their arm gave them trouble.
Do you have any specific therapeutic regimen for these kind of shoulder injuries, nutritional or whatever?
In addition to the adjustments, spinal and shoulder, and the tractioning exercises for themselves, I'll have the patients take something like Ligaplex, I don't know what you have out here. Okay, Nuplex is another good one. We have a company there called Civia that has Copab, Niapress, all for strengthening the soft tissue and tendons. So we will supplement them with that.
What about exercises, Codman exercises, or walking up a wall, anything like that?
They can do those too, depending on how frozen the shoulder is. If it's frozen a lot, I'll have them do the wall walk. I'll also have them take a broom and grip it about the width of their legs, and with the good arm, shove the bad arm up, you know, that type of deal. And help limber it up for them. Because if they don't exercise, no matter how good your adjustments are, or how they nourish it, it can still remain restricted if you don't get it into motion. And another one is the swinging this way,
Does there make
this
any
type of
difference?
action here.
When you have them do that Codman type of an exercise, do you have any preference in what direction, or does it make any difference?
Well,
This way?
I always like them to go forward with the arm here versus back, and circle in toward the body here versus out. Because that's the way Dr. Gonstead did it. He felt that definitely going opposite there could throw it off. So he always went forward. Anybody else on the shoulder?
Is that, you know, the versa right on the tip, does that ever get stirred up by subluxation, or is that just a neuritis?
Well, to say it's stirred by subluxation, I think is a neuritis problem. Are you just saying?
Subluxation of the shoulder.
Oh, yeah, I think so. Strain sprain there can cause the inflammation, edema to cause pressure against the nerve at that particular level, I think.
You find that you could all get a nerve problem involved in the shoulder?
If we were to go with the percentages, I'd say yes. And whether that, you know, that may weaken the shoulder to allow it to have the problem that it does. Overuse of the right or left side, according to whatever hand is your hand that you're using all the time, is going to work the back of the shoulder and the nerves in that area more so. So it seems like it for sure. So something I didn't mention is we assume when we talk about these extremities that you've already taken care of the spine or are doing that. And we assume also that you x-ray them, the extremities. And what I'm showing here today certainly isn't all the methods you can use to do these adjustments or take care of these problems, but it's the ones that are used at the clinic routinely and what will get you through what you need to know for the problems that we see.
How many times have you run into a case where they probably having a problem with the skeleton causing shoulder?
Causing the shoulder? I myself never had that, Dick. You have apparently, huh? Shoulder. What's the connection? Except where it is.
It's something that Alex talked about.
see most shoulder problems are in auto accidents. That's,
How about
the
with
traumatic shoulder. Huh?
with the alien relationship?
No. Okay. Says that's been my experience.
Now with the elbow, if you don't mind standing.
Oh.
With the elbow,
Oh.
must be allergic to them, huh?
No, no, no. You listen to
Are you? With the elbow situation, we can have a strain at either the attachment of the radius or the ulna to the humerus. The old tennis elbow, as it's diagnosed, is something that we can do a wonderful job with, both in light manipulation and in, of course, nerve supply and nutrition.
Put the word in this one, it's sore.
All right. With the radius, invariably the pain will be localized right over the head of the radius where it attaches into that fossa on the humerus. Depending on the size of the patient, small versus an adult, we may use a thumb contact on the head of that radius or a thenar or a pisiform. The smaller the size, like a child, of course, we'll put our thumb on there. On an adult, it won't be comfortable to use a thumb contact on that radius. So nice padded thenar will work the best, or a pisiform. Right on the head of the radius.
Back in the fossa.
Right there. He's got a fairly tender one here. What we'll try and do is pump it a little bit, see if we can get a bit of a set there. Assuming from x-ray now, you make sure there's nothing else there like a cyst or whatever. We'll grip the elbow with the palm of our hand, placing the thenar on the head of the radius. With the other hand, in order to weaken their resistance, you can grip their wrist with a few fingers and put the little finger behind the hand, flex the wrist, and that resists their power in their arm. Then what we'll do is turn the biceps toward the side of the ribs and first try pumping it straight in like this, very lightly. Add a little bit more of a set to it. It's kind of a little whip set with the forearm and the elbow itself, trying to work that into position. If you can't get any place with that, then what we'll do is grip the wrist, turn the elbow so the fossa is up, and then take it straight up this way, working a little bit straight in. Doesn't feel like there's really much misalignment.
Really big setting this right, so.
Bit more of a job.
Still tender though.
It's in the shoulder.
Shoulders causing referred pain, yeah. Shoulders could, or the wrist could too. Now, I'm not feeling any crepitation in here really today. With this much pumping and working around, you should be feeding some movement if it needs to be moved like that. But that's how we do it. And on the smaller person, putting the thumb on it like this and doing the same thing like that. Now, if the pain is localized over the olecranon process in the back of the elbow, invariably it's the ulna that's doing it. So we'll just take the palm of our hand underneath that, and again with the palm up on the patient's hand, a little bit of a traction, whip type set here, lifting it straight up like that. I'm pushing down slightly with the wrist portion and lifting up with my palm and then click into position. You may have to work them a little bit side to side and then up to get them to go. And they will get immediate relief with those, at least take a lot of the edge off of it, the soreness he still has today because of the inflammation that's been in there. But when we reestablish the connection, that will relieve it, the sharp pains tremendously. In the tennis elbow situations and athletics, we'll have them put the band on there or whatever to help stabilize it. But they'll need to be set, and of course we will help with the nutrition and the nerve supply on those. You can set them yourself if you need to, just like this, right into your body like that.
On that radius subluxation, misalignment, is that just straight lateral or is there any rotation? Or is it very-
Usually just straight lateral, just swells right off of the fossa there. If it's bad enough, you might have a deviation more than that. But on all of these joints, when they fit into a little socket or a fossa, if you just help line it up and show it that direction, they will suck itself back in there or want to be there for sure. So they shouldn't be too hard to move. Now, another possibility in the elbow region is having a separation where the humerus meets the ulna. And this is very rare. But it can cause localized pain right inside here. No radiation anyplace, just localized right inside there. And your adjustments on the ulna or the radius just don't make it. Nerves, nothing, shoulder, whatever. If you take a film of the shoulder, or excuse me, the elbow, like this, you will see an opening of that space, a separation, a swelling in there, causing that protrusion and pain. What you do is take the palm of your hand on the medial epicondyle of the humerus and on the ulna itself, and flex the elbow just enough to get some motion in there. You'll have to kind of toy around with it to see how much flexion you need. You definitely can't set it with it straight out. But let it flex slightly and then take it straight across. Pump it across there. You get a little click, some movement, sometimes a slight audible, straight across, and that'll relieve it. That's assuming everything else has been checked out and you're getting no place. That may be a possibility there. I've seen 2 of those. One's at the clinic and have a gal in Madison that has that. And the one person was going to go in for surgery for it because they couldn't find anything else. And a couple adjustments and the pain is gone.
So these definitely recur.
They'll be recurrent because of activity apparently that got them that way. Just like that. Just enough flexion to allow you to take it across. If you flex it too much, it's too sloppy. If it's straight, it's locked up. So just enough flexion to work it across.
Yeah, I see, that's good.
Contact right in here, the pain's localized right in here. Grip it with your palm, flex it a little bit, work it straight across. Now, I have to stabilize the other side with the other hand, just like that. And you should get a click in there, much like the second you do the ulna and the radius, or either one of those. What you're doing is just closing that joint there. The ulna could have side-slipped a little bit, or the humerus, just, that's hard for that to move, but the separation can occur with just enough swelling to cause pain in there. Now, getting down to the wrist.
Bill, we'll take a little break.
Okay. The common thing to occur here is a strain, sprain, maybe subluxation of the carpals superior. And what happens is either through injuries, athletics, whatever, the hand gets forced in this direction, flexion, or maybe a fracture, something, and they strain upward, and they will prevent the normal extension of the wrist, or full extension. First thing we'll do here is a traction move. You can grip the patient's hand, lay your finger, index finger across the carpal region, traction the wrist, and then just extend it up like that. And work it just a little bit. Most of the time you'll feel those click back into position. That's the safest way to work with these. Comfortable for the patient. Traction first opens the joint, lift the wrist up, and work it a little bit. Now, sometimes the carpal tunnel syndrome, when it's diagnosed, is caused from this. So it can help that type of situation. Otherwise, localized pain, restricted movement, sometimes pain on the radius side or the ulna side can be caused from carpals that not only come superior but go lateral or away from the center of the joint. So I'm gripping the wrist, laying my finger flat across the carpals, stretching and flexing and turning a little bit. As I do that, that seats them down, seats them in as I turn it this way and release it. If you can't get anything to happen there, you can take your thumb on the carpal, one thumb on top of the other, stretch the wrist out, do a little bit of a whip type set here. Keep this very controlled and don't come way up here and way down there and snap that wrist because it can be very painful.
Take a little fun on my practice.
So that's another way to work with these two. Just like that. Once in a while the pain on the inside here on the radius or on the ulna is due to a lateral deviation of the radius or the ulna. Here, just take your thenar, stretch the joint and traction once again with your thenar, put pressure on that radius or the ulna and set it back into the center where the carpals are. Or squeeze the wrist, traction and squeeze the wrist and work it like that. And we'll bring those together and take this straight out of there.
Is that mostly total carpal surgery?
Yeah. Yeah. That's about all we do for the wrist. coming down into the fingers, thumb area. The thumb usually a little more complicated in that you can have misalignment where it meets the carpals. Usually you'll have to set that back down and in. Out here it could either go up or down. Motion palpation will tell you the good direction. Obviously you're not going to shove it more that way. It has to go through the fixation that may be pulling it down or lifting it up, according to what you feel in motion palpation. The other fingers, usually a matter of just pulling them straight out to loosen the joint when they're jammed or stuck or something like that. The metacarpals up in here can cause some pain to radiate in the finger region. On those, usually they'll rotate or twist. What you'll have to do is grip them with your thumb and your fingers, stretch the joints, and then just roll the bone with your hand until you get it to seat. You may or may not feel anything click in there. So tractioning and then just turning them, whatever one is causing the problem, will help seat them back into position and relieve the area. That's not very common because it's pretty hard to do something to make that twist in there, but that's usually what occurs. Maybe in athletic or injury or some type of car accident, etc., that could happen. That's about what we do with the hand reaching. Any questions about the arm, shoulder, elbow, hand? Or leave it there? Great. Knees.
You want to sit here?
Yeah.
Okay.
You sit. Great. With the knee situation, something fairly common in the practice. There are two very common directions of misalignment with the knee situation, or three I should say. The one that causes the medial meniscus pain when the knee is rotated or a problem invariably is what we call an AIN femur. And in that situation, what's going on is the femur itself is strained medialward, internal, and then on that medial epicondyle it will rotate forward or anterior. What that will do is cause localized pain on the medial meniscus. It will cause a rotation appearance of the patella on the AP film. So what we'll do is take the film standing with both toes pointing straight ahead, regardless of their foot flare, pointing straight ahead so you have some type of constant to work with. It'll take a 14 by 17. When we look at it, we look at it from the front. If the patella is out to the lateral aspect of the joint, that's indicative of an anterior rotation of the medial epicondyle of the femur. So it goes in and rotates anterior. So what we'll do is palpate for the meniscus of the joint, thenar contact on that medial epicondyle and the medial and anterior aspect, including the cartilage. Traction the leg, and then lift it up and set it down and in like that. Some of those, they go very hard, some of them go very easy. Some of them, it'll take both hands to work with the joint to get it loosened up. So what you can do for those, very simply, is just cradle the lower leg in with your legs. With both hands, you can grip the knee and have a little bit better control. Now, in the chronic case, we'll need to open the joint up because in the chronic case, you'll see a degeneration of that cartilage on that AP film. It goes in and then starts to wear that down, so it kind of tilts down. You'll narrow the space. That's another indication of an internal femur. So with this leg, I'll put pressure that way, holding, stabilizing on the lateral aspect of the cartilages. Do it very gently, lifting and working it over and setting it down, pumping it, and you'll get those to slide, sometimes inaudible or click. Be very careful on those as you work them gently into position, kind of determining where the flexion point allows it to slide across and back best, rather than that whip type set. On a smaller, on a younger person with a good cartilage that's acutely swollen, you could do that snap type set that I showed you first. And the degenerated ones, you're better off to work with both hands and just kind of gently nudge it in there. And you can give them tremendous relief with those older folks. Of course, their weight, etc., can be a factor of the pelvis. If you're taking your pictures and they have a localized pain in here, and they have nothing wrong with the knee that it looks like, no injury, no history of trauma, the knee pain can come from in here, the ilium, first, second, third lumbar, perhaps an arch problem or ankle problem. So look to those besides just the knee itself. If they have the pain now on the lateral aspect of the knee out here, usually the external shifting of the tibia will cause that, and it's common to have, in addition to that, a posterior rotation of that lateral epicondyle of the tibia. So we call it a PEX tibia. Causes the localized pain out here. Now to do that one, we can do it either sitting or face down on the pelvic tabular hylo. If we do it sitting, we'll have the patient sit back as far as they can on the chair, and of course on this one we'd have to lower the back piece. And have them rotate their leg a little bit, and the chair will stabilize the inside of the femur. Then we'll flex the knee with either pisiform or thenar contact just above the fibula insertion. Flexing the knee, we'll traction it, turn the toe in and set it straight across like that. Kind of pump it straight across. Once you turn the toe, you don't have to worry about twisting the leg. That'll aggravate the cartilage and the soft tissue. So traction it, set it straight across, goes the EX. That's the type of knee misalignment that will cause a lateral pain out here. On the film, you may visually see a lateral shifting on there in the alignment process. What's common with that posterior rotation is to see a narrow space between the fibula and the tibia in comparison to the other side, or they could both be narrow. After you look at several of these, you can kind of get an idea about how much space you should see between those fibula and tibia areas. And when it looks decreased or increased, it's indicative of some rotation in the tibia itself. Now I'll show you the other way to do the PEX face down, and also the other common misalignment.
Which, my right top.
Yep, it's your right knee. Now, PEX tibia in the prone position, you have a lot of leverage to do it here. We're standing on the opposite side of the tibia that's involved. It would be a good idea to have someone in the room on this side of the table stabilizing the femur for you. Grip the ankle with your inferior arm, palpate where the fibula inserts, it's right there. Go underneath the knee with a finger or two, just above that fibula. We stretch down, turn the toe in, now flat, straight across this way. A lot of power there. I said that some of them you have to give a pretty good tug. Straight across. The key in any of these is the traction mechanism. Open the joint up, bring it across. That's all the
Yeah.
Are you on the fibula head when you do that?
I'm just above the fibula head. Don't get on the fibula head or you might pull that off. Just go above that, so that gives you about that much space, one or two fingers to fit in there. And then just pull it flat. Once you have that set up, you traction, turn the toe in. Don't twist the knee by lifting up. Pull it flat across as much as you can. Otherwise you will cause too much pain trying to twist the knee. Another last resort way to work with that in this position is tractioning the leg with both hands and setting it like that. Pull and set at the same time. You may get it opened up enough and then turn it, it slides back across. What's that?
Oh, okay. Right, thank you.
Now, the last common knee misalignment that we run into is called the posterior tibia, straight posterior. And on that one, many times you see a big goose egg in the popliteal fossa. They'll complain that the knee wants to give out when they go walking, especially downstairs or down a hill. What's occurring there is that tibia is shifting straight back, and of course it expands the ligaments. It will cause a muscle bunching in the posterior aspect where the fossa is. In the anterior aspect, it can cause pain underneath the patella or swelling or fluid around, underneath, or above the patella. A locking mechanism to where they'll complain that once they get their knee straightened out, they can't bend it, or once it's bent, they can't straighten it. And the giveaway business. The femur fibula is going to just slip right off of the tibia. On that one, there are a few ways to do it. position, if they can allow full flexion of the knee, then you can do a scissors type move, and that is gripping the ankle, placing the palm and the index finger and thumb behind the tibia. And when I do this, I'm putting pressure in this way on the posterior part of the tibia, and I'll do a scissors type set. And when I traction here, I'll scissors it like that, thrusting here and thrusting here. Now, if they can't tolerate the full flexion by like this, don't try that adjustment.
Is the thrust on the left hand, is that inferior with the?
It's somewhat inferior to where, if you could see the angle that I have here, I'm trying to come straight feet away through the back of the tibia.
Okay.
But in this position, I'm almost following the plane line of your thigh here, because by the time I get the leg up here, I have to lay it pretty flat, and you feel that? To go straight in like that. Okay? Just like that. Now that's a real simple one. You could stand on either side to do that, really. If it doesn't work like that, well, let's say they can't flex the knee enough, then you'll have to get down along the side of the table and place their ankle over your shoulder, gripping the back of the tibia with both hands, and then flex as far as they can go where it locks back up just a little bit. There you've got the slack out, you've got the joint open as much as you can in the anterior, but you don't have it locked up by taking it to where they have the pain. Back up a little bit, and then when you thrust, it's at that same angle, down into the table. And some of these really take a lot of power. And you have to kind of learn to feel when they relax as much as they can. With both arms, you set it straight down, like that. So those are the two main ways that we'll do that. Yeah.
If you have an athlete that is, been diagnosed as having some sort of cruciate damage or something like that, and they do have that posterior tibia, you go ahead and set it like that anyway to support it somehow, and just have them stay off of it until it heals up. Or
The question is about the ligaments, cruciates, etc. If I have two ligaments or more that I feel are torn, I will not try to manipulate it. One, for sure I will. Two, depending on how bad the pain is, I probably will. But after that, I will not. I think after that, the damage will require some surgical reduction. So when you do your test, you can determine that. Otherwise, with support again, with the ligament sprain or tear, the nucleus or whatever you've got, ligaplex, is great to help nourish those. Taping in athletics, for sure.
Is there, on the AP X-ray, we have a line drawn. Is there anything you can see on the left? Can you see a posterior tibia on the left X-ray?
If it's really gross, you could. It'd take a lot of them to look at in order to determine the misalignment unless it's really gross. We're relying more on palpation for the puffiness and swelling, or visualization of the goose egg or swelling around the kneecap. Symptomatology, an awful lot, in that they talk about the locking business or give out business. The mode of injury a lot of times.
Bill,
Yeah.
is that swelling referred to as Baker's cyst?
I don't really think that's the same as a Baker's cyst type of swelling. Well, it may appear, but it's not there for the same reason. It may look the same, but it's not there for the same reason. Anyone else want to keep that?
What about that one with the patella that right, that just low back?
You mean that it slides up in the sheath here?
Yeah, or comes up out of the little channel or.
Yeah. That could be a nerve supply problem, not likely, more commonly that it was an injury-related problem. And what, if you happen to get that, what we'd have you do is lay the patient on their back at this table or the high-low table, flex the knees slightly to take some of the pressure off of the joint, and then support it with a book under there or something. And with your hand, superior hand, slide it right back into position. That's assuming you've x-rayed and everything else, and you want to do that type of work. And they usually will slide back. And if they're unstable and slide around a lot, probably is a nerve supply problem, or nutritionally, the chemistry of the joint is poor. So then supplementation will be in order there. A lot of times when these old folks, no matter what the knee problem problems are. Or even if you don't see knee problems, let's say it's their weight that's bugging them. And they tell you they don't eat anything. Some of them, for them, that's a gallon of ice cream before they go to bed. You can help relieve those with some tractioning of the knees. And on that, we simply lay them face down, either put our hand in the popliteal fossa, or if you want to put a towel in there, and then just stretch the knee, hold it 2 or 3 seconds, and then slowly let it back. That takes a lot of pressure off the knee for them and can relieve them a lot. And that may be something you'll have to resort to if you cannot get the desired adjustment on the first couple of visits. Stretch it out, expand it, that gives them relief, and then you can go in there and set it after a couple of times. On some of these old folks that have those chronic knee problems, you can instruct them to do that at home by putting a towel behind their knee and just pulling their ankle toward their thigh and stretch that knee out to give them some relief also. Because you know when the cartilage is shot, you can adjust it every day probably. It just doesn't hold too well, but that will help give them some relief. We do tape those knees. Routinely use that 2-inch Johnson Elasticon, I think it's called. It has the air holes in it. And what we'll do is tape it from the lateral aspect of the tibia up and across in here, in the inside of the thigh for the AI and femur, and just the opposite across here for the PDX tibia. And most folks that we tape will do it both ways. And that will give them some stability, kind of tightens things up a little bit more for them. Let it hold maybe a couple of weeks instead of a day or two. And we just let them leave it right on there. Bathe or clean up, work around that, and just leave it on as long as it stays. When it starts to curl back, of course they can pull it off. Okay. And the last area of involvement then is the ankle and the foot. And I'll need someone up here. Oh, okay. Why don't we put you back on the chair? You can sit on here and then I'll sit on the chair.
Oh, okay.
And we take, let's take the right shoe.
Right shoe?
Huh?
You're pretty brave.
I'm assuming you bathed this morning. Shower.
You can assume a hell of a lot of things, but that doesn't necessarily make it true, I'll tell you that. Okay, there you go.
All right.
It's all yours.
Thank you very much. The routine ankle work that we will do in the sprain, whatever, is treating that situation where they turn their foot underneath. Like we shove the calcaneus up posterior and superior. The pain will be localized across the top of the ankle around the talus, cuboids, and it may also have pain behind or where the Achilles tendon attaches. And they'll complain that they cannot dorsiflex their foot, feels stuck or restricted, hurts when they walk, swelling, etc. So what we feel happens is the calcaneus gets shoved up, cuboids get turned down and under, so that makes the talus sprain upward, that restricts the dorsiflexion, retains the swelling and pain along the side. Now we can do that in a one-part move with both hands, and that we will grip the calcaneus with one hand, take our hand across cuboids and talus with the other hand, dorsiflex the foot, and pull down on the calcaneus and setting across and in this direction for lifting of the cuboids and setting into the talus. Depending on how tough they are, you can do it this way, one tug and pull. And some of them you really have to give them a good yank. So they may have to hold on to the bench or the chair instead. Now on these, if we can get it right at the time of injury sprain within 15-20 minutes, go ahead and set it. If it's swollen up, ice it a couple of days, get the swelling down, then you can work with it. Otherwise you're going to cause more capillary tear and soft tissue trouble if you try setting it when it's swollen. So get her iced down. It's just like that. Now, if you can't get everything out with both hands doing the whole works at once, then we'll take both hands, pull down on the calcaneus first. Bring that down. That will relieve the heel pain and some of the pain in the talus. Then you can take both hands, lifting with one, pulling across and down with the other at the same time. With the cuboids, cuneiforms, whatever we got in there, I forget. You got that on tape? Right there. This goes up, this comes across like that. Now, if anything seems to hold on, it's the pain and swelling along here. And that's why you have to really lift that up and across and pull it like this. If the talus is the only thing that's holding on, you can take your thumbs and set it in like that. You can take both fingers right over top of it. You can take your thenar across it. You can take your pisiform down and in on it, whatever you want to do. The point is to get it back and in so they can dorsiflex the foot once again. When it's stuck like that and you set it, they'll get relief right away and return us some motion right away. Now, the arch situation, navicular, localized pain in here, flat foot, whatever you might have. On those, we can give them some relief. On children, improve the arch so it can grow better and put some support in there in their shoe, etc. In a small person, thumb contact supported by the other thumb or pisiform. Traction of toe, the big toe, down and toward the center of the foot to open the joint up. And then we set it up and across. It's got to kind of cut an angle about like this, not straight up and jam. It's got to fit at an angle. So we'll set it across and up like that. Tractioning first. You can use your thenar for contact. You can use your pisiform itself for contact on the adult. Thumb is too painful on the adult. See?
Maybe you can do that then. You can press on the I'm sure you can.
Just like that. All right? Now getting down to the bottom here, metatarsals, that's the calluses on the bottom, corms on the top, toes curl up, etc. Usually due to heels that are too high, because it forces the foot. The heel up too high makes the toes compensate and drops the metatarsals down. You're going to need some metatarsal pads, most likely. What we'll do to set those is take our index finger, contact right at this knuckle underneath the metatarsal. You've probably all seen this one done. You lift, or you traction the toe and lift up, and usually we get a little click, and you can do each one, whatever one's needed. With the big toe, might be a little more involved, bunion type situation. In addition to dropping down, it can also create the bunion or the protrusion of the toe from lateral from the center of the foot. You can relieve those usually, but you can't straighten them out cosmetically usually because they've been there so long, or the shoes they wear are going to do the same thing again. So what we'll do with our index finger, get underneath the joint, the big toe, and then stretch the toe out as much as possible, and as we lift up, we also go in with it. And what these bunion situations will require is mostly stretching, just a light pumping action, lifting up and going slightly medial. And you might feel a little grate or gristle in there, or a slight sliding or clicking. That's about all you'll achieve. And if you get that, I leave it alone. We relieve the situation. They can traction it at home, or you can do it each visit when they come in to help it keep relief in there for them. So that's about the size of it for what we do in that situation.
It's not much of a thrust on that.
No, not at all. They're not going to let you hardly traction it, much less thrust on it. So,
You'll learn that pretty fast, so.
yeah.
I learned that on my wife.
Uh-huh.
Here's the whole way too.
Yeah. Stretch it out, traction, first thing, and then that opens the joint so you can slide it across a little bit. And as you go across, lift up a little bit, and you'll get a little movement in there usually. If you don't get the movement, I wouldn't persist with it for a long time, at least in the beginning. Just traction it and pump it in that direction. And then the next visit, pretty soon you'll get that little bit of a gristle feel in there, or a click, or a slide. You'll know when it moved a little bit. And that's all it takes most of the time to take the edge off of that pain for them. And if they're smart, they'll change their shoes and lower the heel, and they'll improve it.
But it isn't always shoes.
You wear high heels.
Don't you think a lot of being able to injuries, malposition,
Inch.
bones in the ankle?
Sure it could.
Because I see people with all kinds of shoes, still have bunions in all ages. It just has no respect for age.
Not ribs.
Oh yeah, I forgot those ribs.
The lumbar
Wait,
part.
before you go,
So assuming that you've got it assuming that you've got it aligned and in motion as good as possible, nutritional support, I don't know what else to tell you. You probably have some permanent damage if it's been run over or something. You're not gonna change that, huh?
I have one. Yeah. Oh, I don't know.
Okay, for the rib person, in the front, when the rib misaligns into the sternum, causes once again the bulging and protrusion, localized pain, assuming it is definitely the rib and not a rotating thoracic or intercostal neuritis that's causing trouble. We will set it an traction move just like I showed you with the clavicle, except we'll just be down here on the rib head, whichever one is protruding. Again, have to raise the arm up and stabilize and bring it up and across and open it out like that. And then we'll click into position. If it doesn't click, stretch it half a dozen times, let it relax, repeat that again, and that'll take the pressure off and you'll improve those tremendously. Cosmetically, once that's been strained off of there, it may look like it's bulged out from there on out to some degree. So I wouldn't worry about it seating back and looking like the rest. You need the pressure off of there, and then through a good spinal adjustment, make sure that the rotation back in the thoracics or wedging is not causing a compensation there to make that pain exist. As far as from behind, usually the rib will slide up in toward the vertebra, and so we'll just contact standing on the opposite side, flat hand pisiform, push it medial to lateral, feet away and medial to lateral away from it.
Follow the rib.
Just follow the angle of the rib. Yes.
You see that on the film?
I suppose you could if it was really shoved up in there. In comparative value, looking at the ones above and below. But, you know, when you have factors like scoliosis or poor lumbar or mid-back or cervical curves that will distort that already and make it look like it's off and it's not. We'd go to that rib if someone had an injury for sure to the rib cage, or take like a mechanic who's bending over a car fender all day and leaning his pressure on there, and he comes in with a chronic pain that radiates around, and you adjust the thoracics and it just doesn't seem to get it out of there completely. We would add the rib adjustment to that. We'll palpate along the posterior part of the paravertebral musculature, and you can learn to feel for the protrusion of those rib heads. They'll seem to stick up on you. And when you find that, we just set it out and across, following the angle of the rib. I didn't show the scapula either. That's one other one that you might get into rarely. Medial
Yeah.
side over here.
On the side?
Yeah. You've got a couple of people on the side or where you face down. Now on that scapula, it'll usually, if it's a problem, it'll slide between the muscle sheaths, and it may cause that crepitation business in there, or it may again be the chronic pain in the scapula, or underneath it, or shoulder pain, or whatever. It doesn't go away with everything else that you've tried. The scapula is one last thing to give a try. When we stand the patient up and look at him from behind, what we're looking for is the position of the tip of the scapula and its relationship to the center of the spine. And visualizing the whole thing, you can see if one is tilted up or if it's turned in toward the spine. Using the point of the scapula, the bottom part of it, as our reference point, either it'll turn in toward the spine or turn out away from the spine. Now, the most common way is for it to go up and superior toward the shoulder, turning it out. On that one we can do here or face down on the knee chest or the high-low table. If it turns up and out like that, what we'll do is contact on the point of that scapula with our other hand, stabilize the top of it in an traction move, take that around and in, take all the slack out and set it straight down across like that. These you really have to twist them around to get them to go, and you may even have to put this arm back here to get enough leverage to twist that shoulder blade like that. I'm setting here, twisting here at the same time. And what you'll feel when it goes is a sliding motion. Some of them make a little audible sound. That move right there. I didn't do too much. Get the slack out of it and twist it. Now, for the other one, when it turns in, that's a little more difficult. You have to get underneath it here like this and do the the opposite twist when they're in this position. It's a little harder to do it in that position. It's easier to do it sitting. So, when they're sitting and it's turned in, it's very easy to stand on the opposite side, get underneath the bottom of that, lift with the shoulder here, and just work it out that way. Lifting here, I'm trying to just twist the thing in its sheath, that's all. Just like that. A lot of times they'll make kind of a bristle or click type sound in the musculature and can give them tremendous relief. We will combine that a lot of times with the thoracic adjustment. After the thoracic adjustment, then we'll work on the scapula.
Why do you do it in that way?
Well, I think because of when we adjust the spine, we did this first and then adjust the spine, we may disturb what we said over here. Where this is not as much thrust here as this is here. That'd be the only reason. I suppose you could do it the opposite way. I guess that's just in routine. You satisfied with that? That about exhausts the extremity work, I believe.
About fibula head.
Fibula head, don't really work with that too much. I've only set one of them myself. I don't really have too much to show you on that, to be honest with you. The one that I did set, I treated it much like that adjustment or setup on the PAX tibia, in that it was strained off by the top of the tibia. So I just reached underneath it and pulled it back in for that type of set. It made a little click. Yeah, I'm sure you could do it in the sitting position too and use your thenar on there, flex the knee and just set it straight in. They sprain off much like a radius does off of the humerus.
It was from an inversion. That's right. Not the fibula area as well.
I myself don't know the move to show you for that particular type of set.
These whiplash injuries, do you find, just wanted to ask you to what your experience has been with whiplash injuries as far as the extent of the injury, the radiation that's involved, what segments are most common?
With a whiplash injury, the most common segment that's involved in the disc protrusion and expansion in the cervical spine is the 5th and 6th cervical. In a kyphosis, that's the area that catches it most. As far as symptoms that can occur from that, we see anything from restricted movement, cracking, grating sounds, lightheadedness, dizziness, ringing in the ears, pain at the base of the skull, pounding type headaches, migraine type headaches, visual disturbances, eye sensitive to light, pain that radiates up the side of the neck into the frontal area on either side, radicular pain down the arms either side or both, numbness, tingling, burning, cramping, mid-back pain, etc. Sometimes it can go as far as their special senses where they notice a reduction in their hearing, or perhaps blurred vision, or perhaps taste problems, sinus problems, ear infections, ear pains. All those are possible with the nerve roots that are involved there, because it does cause a general soft tissue damage to the cervical spine. Of course, that's where those nerves go to, and the origins of many cranial nerves. Case management wise, what we'll do with those, first of all, is work below the cervical spine. Rather than adjust into an area that's already been traumatized, we will work below it in the beginning, maybe the first few visits or first week or 2 weeks. And what we'll do there, invariably there's a problem lower thoracic, lumbar, pelvis, or combination of those. We'll work on those to help strengthen the spine, to help carry the weight of the head and neck back up here rather than out here after the injury. As we do that, we relieve a lot of the muscular stress and tension. The neck itself starts to come back up and return some of the motion, so we take a lot of the stretching out of that area, and then we can start to work up into the neck. If it's a bad enough tear that they can't hold their head up, of course, we'll use the cervical collar. We recommend using the cervical collar until the area is completely healed when they're doing things like driving or sitting a long time, because automatically we start doing this. Or if you're in a car and you already had an injury, you certainly don't want to get bumped and not have some type of support. We'll use a cervical pillow as soon as they can tolerate that. In the beginning, we'll have them lay on their side because they probably can't tolerate extension or much flexion at all. So forcing a cervical pillow underneath it will not be comfortable. We will use some moderate to mild heat on the neck area for circulation improvement and muscle spasm, that type of thing. Again, you could use the joint ligaplex business to help nourish the area. And as you can, move up into the neck if it's necessary. If you have a 6 or 7 cervical that needs to be adjusted to correct that, then we will move into that later. Once we've got some of the edge off of the pain in the neck and they can return some of the motion. Exam-wise, I like to examine them about every 2 weeks, at least on every monthly basis. Re-X-ray on that basis. We'll do the full spine and the Davis series, functional views, and do that on re-X-ray also. So when you go to your attorney and you have your deposition, you can say something. So,
Bill, what are your thoughts on using ligaplex? How do you regimen that?
how much?
Yeah, what do you use?
I myself use Nuclex, same stuff, different company. In the beginning, I'll give them 6 a day, 2 per meal, probably for about the first 2 weeks to a month, depending how bad the injury is. And then I'll cut it back, probably to 1 per meal. If there are myofascial residuals remaining, which there usually are, and to what degree, I have them supplement that, maybe a tablet or 2 a day, or similar. Something like it, or change their diet enough to get enough green vegetables in or to get minerals in it. Or they can take something like cod liver oil pearls, a little more palatable, and then keep the chemistry in the joint good.
Now, do you, in the general routine of clinic and osteoporosis, do you usually have a nutritional program there?
Yeah. There again, we use some type of calcium and mineral content, and probably a B complex.
Well, CS used to talk about multi-mineral, which was
Right.
very high in this.
Right.
You still do that, any vitamins with that?
Usually, as a maintenance type of thing, it'll be a multi-mineral and a B complex. And the multi-mineral stores you can get, there's many different varieties. Dark calcium is something they use a lot with Dartel. There's some other ones back there, Cal Acid, there was Civad. I don't know what the other companies
Well,
are.
our county itself is multi-mineral, called multi-mineral.
Yeah, they have that too. Cod liver oil again is a good one for multi-mineral in the pearls. I don't know how many of you had to take it from mom when you were a kid, but it wasn't too palatable. Right? You see those nice phosphorus lines in the tibia growth centers. We have 5 minutes and I must depart for the airport. Questions or anything to review? No? Everything's going great? Practice?
What are some of the recommendations you make, say after a car accident, to the attorney regarding future management or
I don't correspond with the attorney until he gives me something in writing. To the patient, I will say, irregardless of the amount of injury, how minimal it may seem, I'll say give yourself 6 months before you sign anything off. For sure. On some of them, I'll say for sure a year. The attorneys, you don't need to say that. Attorneys are going to drag it out as long as they can anyhow. That's just the nature of it. Am I right?
so on future
Nature of
there,
it.
let's say that the attorney wants you to make a prognosis and make recommendations for the patient to
Yes,
care.
sure they will.
What, at that time, what kind of descriptions do you use and what are your concerns when you're
Well,
spelling it out to the attorney?
first of all, when you make your original diagnosis, that gives them an idea to the injury that's involved, first of all. Then, when you do your progress, re-exams and re-x-rays, from that you determine how much better the patient has gotten, to what degree there's been correction made, or you feel there are going to be severe residuals or minor residuals. From that, it gets into impairment rating kind of stuff, experience, looking at the spine to know through experience what was pre-existing, what wasn't, and from that determining, I'm going to need that patient, or that patient's going to need to see a chiropractor once a week the rest of their life, once a month, once a year, full correction. Invariably, on personal injury cases, I'll give a guarded prognosis the rest of their life, because it's pretty much standard procedure in the courtroom in orthopedics that there are myofascial residuals remaining. no matter what the degree of injury is. So whether you give it 2 or 3% disability permanently for those myofascial residuals, or if you end up with a higher percentage according to reduced or non-reduced subluxations, that type of thing, disc degeneration, that type of thing. It'll determine how often they need to be seen. Of course, then when you tell the attorney once a month or twice a week or whatever the rest of their life, then they estimate a reasonable lifespan and the cost of that, projected cost in income raising adjustment from is now 14, it's going to be 20 in 10 years or whatever. Then they all agree on some type of settlement. Personal injury gets pretty complicated.
You
really
base
have to
that
know your
simply
stuff.
on the symptoms, or?
Totally on objective findings. It must be. You go into a court and say, well, gee, that guy said he hurt when I bent his head over, they're going to laugh you right out of there. You've got to say, I performed this test, there are so many degrees of motion, this is a normal range. That type
Well,
of thing.
let's say that the patient has full symptomatic recovery,
Mhm.
but due to the nature of the mechanics of the injury and some orthopedic objective findings, you don't think they're gonna last very long. Do you make it based on that?
Absolutely. Mhm. Sure. As you know, symptomatic relief is not always the, well, it really isn't the deciding factor when care is or is not required. The only case is when we know we can only relieve the patient, from a chronic problem, like the old folk that someone asked about. Their symptomatic relief is what we use to decide when and when not to adjust. But in a case like the PI situation, you have to rely totally on objective findings. Even if they got back 100% of the normal range of motion, foraminal compression tests were negative, as everything was negative, and you saw a good arch in the neck, etc., you're still safe to say you got 3 to 5% of myofascial residual permanent disability in that area. That's pretty much common accepted jargon.
You can concern yourself with the biomechanics, the effect on the biomechanics, as well as symptomatology and all this kind of thing when you're making recommendations.
Yes, you have to.
Yeah.
You have to make your recommendation according to the objective findings. When you're dealing with a litigation, an attorney or an insurance company, it's got to be according to objective findings, because they don't care about somebody who says they got a pain in the neck.
Yeah.
They're not gonna take that as the reason they should pay a settlement or not. And so it's a good idea when you examine your patient, you do a foraminal compression test or range of motion. Say, what do you feel? Not, does this hurt? Some of them are going to say, of course it hurts. They're going to want to have some kind of settlement. So say, what do you feel when I do this? And say, well, it hurts. Well, where? That type of thing. Try and be as objective as you possibly can. Okay, anybody else?
You referred earlier to, deciding to adjust a particular area, not only off of just the reading, but, if you thought structurally.
Mm-hmm.
That's, I've been thinking about that since you said that. How often, is that pretty much just a judgment call on a particular case? There's been a couple of times where, I didn't know whether it was right to do this or not, but I kept getting the reading at the same time, always on her T-cell. And often Bill was kind of palpating lower, like around T12, looked like it was fairly stuck, but no matter what I did, I couldn't find it. And I went down and set that anyway, and it seemed to clear out.
Right. You did the right thing. The question was the reliance on the reading, and hopefully the reading is going to be at the same level of the subluxation. You can get things that appear as readings that are compensation differentials, and so to put it the way Alex said it at a seminar, in your case there, he got the reading at the 7th thoracic. It marked out to be that particular level. There was the differentiation. In palpation and on the x-ray, it looked like it was better to do the 12th thoracic. So in that case, you did the 12th thoracic, you did the right thing. It may look like on the film it's better to do that than where the actual break is occurring. The break may be occurring a few segments above because of a compensation stress, and the chronic subluxation is not really throwing off too much heat anymore. That's common in the chronic situations. The more acute the problem, the more the break is reliable right at that particular level, and the more reliance we put on the brake as to when to back off. Let's say they come in, they still have some leg pain left, but the reading has gone from 20 down to 4 or 5. We will use that indication at that time to stay out of there despite the symptom. So it tells us when to back off. What you have to do is learn through common sense, experience, and good judgment, maybe to rely on the film more on this particular case. The reading isn't really right there, like your situation. Or maybe you can't decide by the film and the reading pinpoints it for you, or the palpation, or whatever. You'll probably have to rely on one or two things more so in each given case rather than expecting everything to be there. Pain, palpation, reading, restriction, x-ray, all confirm the same spot. Those are the easy ones. Anybody can do those. It takes good judgment and experience to know when to rely a little bit more on one thing or the other. That takes a while. I guess we learn that every day. The advantage we have and had was, all his experience through those years. He gave us generalities to look for, where to go for. And that saved us a lot of moving around and experimentation. Yeah.
But that's the things we expect with women, pregnant, people problems that
Gotta be here, I gotta go, pal.
more than right. Yeah, you
I
probably
guess
will.
it'll be all right. He'll go away. With pregnant women, invariably the low back pain comes in there because of the increased weight being carried off to the front, expansion of the joints and loosening. You can give them some relief for that with either a light knee chest adjustment. You can push those on the pelvic table right for the day of delivery if you like. Mid-back pain starts to enter in there, some numbness in the arms will come in there because increase the arch in the low back, increases the mid-back, and so they start throwing the head and shoulders forward. Some thoracic light adjustment gives them relief in there too. That's what you usually expect. Structural things causing musculoskeletal aches and pains, and then perhaps some leg pains or arm pains due to the pressure on those nerves. Still there? Bye. Huh?
The adjustment doesn't take rid of the pregnancy.
No, although I tell you what, it makes the delivery easier a lot of times. And of course, the upper lumbar, you want to have good nerve supply to the ovaries with proper chemical output at the right times, the pelvic alignment, and headaches a lot of times due to the chemical imbalance can be helped.
You find your adjustments get lighter as they get closer?
Absolutely, adjustments get lighter. Sure. Especially in knee chest, you get a lot more added weight there. The joints are a little more mobile, and they will set easy. So be very gentle with them. They're scared already, probably, that you're going to adjust them when they're pregnant. So very, very light.
Just about one more, and we gotta hit the road here.
Yes.
Vascular problems.
Well, you can probably help those cases where the vascular problem is due to the poor elasticity in the vein or the circular muscle of the artery if it's caused from nerve supply. The varicose vein type situation many times can be helped with low back adjustments can improve the elasticity in that and the muscular support around it. So we've had those cases where it's taking the vein back in or hemorrhoids. As far as leg pain is concerned, to decide, you mean whether it's a nerve pain or blood problem? I feel that, well, if you have one of those vascular analyzers, you can determine what that means. If you don't, if you have the leg pain that's mimicking sciatic and you don't get some improvement within a couple of adjustments, I think you better get another opinion. If it's a localized one-spot burning type pain that doesn't move, then it's a chance that that's a clot maybe or some type of vascular problem. We're looking for that nerve pain to change position when it's referred from the lower back, moving down. That's what we want to see. If it's not moving, it's doing something within about 3 visits or so, which you should know in a couple of days. I personally would want to get rid of them or at least share some responsibility.
Bill, thank you very much.